21 patients developed AKI, and the baseline urine proteins were compared to those of 21 propensity matched patients who did not develop AKI. So further in this consult chart, we discuss that we enrolled a patient at 145 patients as per our inclusion criteria. Then 19 patients back out from study, one got this ATT and two got kidney stone. So 22 patients excluded, and at baseline we got this number of 123 patients. Further on, we again exclude some patients, 29 patients, because they have a follow-up of less than 3 months, and the patient who died in less than 3 months are 12. So now again, the patient with at least of 3 months of follow-up or more are 82. From these 82 patients, 21 patients got AKI, and 61 patients developed no AKI. So in AKI patients, 15 survived and 6 died, and in non-AKI patients, 59 survived and 2 died. So this is the analysis overview. So we compare 21 AKI patients with 21 non-AKI propensity matched patients. In mortality group, 20 patients who died versus 20 who survived, and again later on 6 patients who had AKI and they died versus non-AKI patients. So using this LCMS comparison analysis, we've done this enrichment analysis, pathway and networking, protein-protein interaction, and later on biomarker validation using ELISA. So this is the proteomics analysis where we use volcano plot to find out the fold change in the proteins and what proteins are upregulated and downregulated. Later on, this VIP chart, that is the visual importance projection chart, which showed the importance of that particular protein higher in that group. So this is a part of this PLSDA plot, which is a partial least special this DA plot, where we can clearly see the differentiation between the two groups. This is just an upgraded form of this PCA plot. In this PCA plot, the same result we got, that the non-AKI group is clearly differentiated from the AKI one. Then we done this heat map analysis where we find out some in the top 50 proteins, we got some proteins which are significantly higher along with the fold change. Then later on, we done this gene ontology analysis where we find out what are the biological processes, cellular component, molecular functions of these proteins. So using all those experiments and analysis, what we find out that in 123 patients, they are age of 50.94 years and predominantly males, and they were recruited and were included for the analysis. So common etiology included alcohol, following NAFL and chronic viral hepatitis. And on follow-up, what we find out, 17.07% individuals had AKI in this outpatient setting. So this is a panel of biomarker which we find out significantly higher with particularly this beta-2 microglobulin. We find out 6-fold change from the baseline. Later on, we have done this ORAC analysis for both B2M and NGAL. NGAL in the mortality group, which is it clearly in the mortality group significantly higher with the ORAC value of 0.9908 and a p-value of this less than 0.001 with cutoff value of 354 nanogram per ml. The same result in the 21 patient who got AKI versus non-AKI, the B2M is highly significant and the ORAC value is 0.96. So in conclusion, the incidence of AKI in outpatient with decompensated cirrhosis is 17.07%. NGAL may be act as a mortality marker in the DC patient with AKI, and the panel of biomarker, that is beta-2 microglobulin, uroplakin, cornifin A and B, urinary retinol binding protein, uromodulin, which is also known as Tam-Horshoff protein, may help in the identification of proteins who have a higher risk of AKI in the development. Thank you.
Nice presentation.
Thank you, sir.
So this issue of NGAL versus other biomarkers, beta-2 microglobulin is only 1.1 times elevated. But did you compare between the two ROC?
Yeah, I've compared and there is no significant value.
It was not significant.
Not significant.
Okay, fine. So do you propose a panel of biomarkers, or NGAL is superior to almost all of them?
NGAL particularly superior in the mortality group, but in that 6 patient who died and had AKI, the NGAL and beta to macroglobulin both came significantly higher.
Fine. So in patients who had AKI, people who died versus people who did not die, was there a difference in cutoffs?
Yes, sir. The 364 nanogram per ml, that is the cutoff for NGAL in the mortality group.
Between mortality and
survival.
Okay, fine. What was the sensitivity, specificity, AUROC?
So it's 100 and 0.8, I guess. It is in analysis, but the p-value I've showed you.
Yeah. Yes, sir.
Anybody from the audience? This is our group paper. So
why that newer criteria for AKI has come? AD-IGO instead that
criteria.
why you follow that this old that
Because at that time in 2019 that IC criteria was
because that new revised criteria for AD-IGO has come, that is very precise and very exact.
yeah, this is 5 years work. So when he started, he is a PhD in our department. So that time we were following the old one. Dr. Paolo, you want to make any comment?
NGAL, that is not available in most of the.
Yeah, it is not. This is part of the research tool still.
Because that will characterize whether it is ATN, that is the highest, that is the level that is found, and then intermediate level, that in HRS, and a patient with the pre-renal AKI, that is the lowest level. That we can also correlate according to the prognostical, because the progression of AKI to HRS is very important. That we can prognosticate early, because NGAL that if you.
Yeah, okay. Dr. Paolo, you want to make any comment?
You're suggesting that it is important to measure NGAL urinary level at baseline in patients with decompensated cirrhosis?
Yes, sir.
Did you classify the type of AKI that this patient had?
Sir, actually, we regardless of etiology of the decompensated cirrhosis, we just see the emergence of AKI in this patient on the follow-up. Because
the 6 patients who died, urine protein was suggestive of AKI?
I'm not sure, because the diagnosis of that ATN and PRH, particularly in the hospitalized setting. So all of this is in outpatient setting. So that's
no patient had the ATN.
It's the most probably first
All
kind of
stable patients.
Sir,
Thank you, Dr.
I agree with you,
Agarwal.
sir. Actually, AK classification should have been done in this patient. If your NGAL were studying as a marker, NGAL as a marker, as he said, it is sir said it is elevated in ATN, mainly intrinsic renal injury. If the prognosis is different, HRS is the worst prognosis. ATN somewhat middle of renal.
Here we wanted to highlight the proteomics part.
Yes, sir.
So we'll do that.
Yes, sir.
We can discuss it later. Next paper. Yeah, Dr. Vijay.
Thank you.
Good morning, respected chairpersons and all other dignitaries. I am Dr. Vijay Narayan from Government Medical College, Trivandrum. Today I will be presenting my paper, which is titled Outcomes of Vasoconstrictor Therapy for Hepatorenal Syndrome Acute Kidney Injury in Acute on Chronic Liver Failure. So, HRS-AKI is one of the most challenging complications of advanced liver disease. The APASL consensus on ACLF states that there is very limited data on vasoconstrictor therapy in ACLF patients with HRS-AKI. Whether HRS-AKI and ACLF should be handled in the same way as decompensated cirrhosis is still uncertain. So we evaluated the treatment response and outcomes of vasoconstrictor therapy for HRS-AKI in patients with ACLF. We prospectively enrolled 75 patients with ACLF and HRS-AKI and followed them up for 90 days. And ACLF was determined by the APASL definition, and HRS-AKI was defined based on the International Club of Ascites diagnostic criteria. And we performed the survival analysis with the Kaplan-Meier method and the Cox regression models. So coming to our results, among ACLF All the patients were divided as complete treatment responders, partial responders, and non-responders. Complete treatment responders were those in which the creatinine came to within 0.3 milligram per deciliter of the baseline. Partial responders were those who had a regression of the AKI stage, but creatinine did not reach within 0.3 of the baseline. And non-responders were those who had an increase in the AKI stage, or creatinine did not come down significantly. So, among ACLF patients, complete response to terlipressin and albumin was observed in 32% patients. 21% had a partial response, and 47% had no response to treatment. And 17% patients had reported adverse effects to terlipressin. Then we again subclassified the response rates based on the grades of ACLF. As you can see, in grade 1 ACLF, the complete response rate was 57%. It came down to 33% in grade 3 ACLF, and in grade 3 ACLF, it was as low as 25%. And the predictors of treatment response, which we found out, were serum bilirubin, baseline serum creatinine, MELD score, and the ARC score. So this was a summary of our flow chart. So we had 75 patients, and out of which 53% were treatment responders, in which 32% had a complete response and 21% had partial response, and non-responders were 47%. Some of them were offered alternate therapy with octreotide, midodrine, and noradrenaline, but the response rates was not very good. And the incidence of RRT in non-responders were 18 out of 29 patients had required RRT. So non-responders had significantly higher mortality at 28 days as well as 90 days, and the HRS CKD and the need for RRT was also higher in non-responders. And this is our Kaplan-Meier analysis, and the mean transfer-free survival was significantly longer in treatment responders as compared to non-responders. And when we did the Cox regression analysis for independent predictors of 90-day mortality, we found out that MELD score with a hazard ratio of 1.17 and non-response to treatment with a hazard ratio of 2.84 were the independent predictors of 90-day mortality. So we had another study, similar study on decompensated cirrhosis, HRS-AKI and the response to terlipressin, which was presented at INASL last year. So this is a comparison between both our studies. At baseline, the age in decompensated cirrhosis was 58, while in ACLF it was 50. Total leukocyte count was significantly different. In CLD it was 7,700, and in ACLF it was much higher, 12,300. Bilirubin was also significant, 4.3 in cirrhosis and 12.6 in ACLF. MELD score at baseline was 26 in CLD and 33 in ACLF. And response rates to treatment, complete response was 54.8% in DCLD, but 32% in ACLF. And based on the grades, in child, it was 75, 55, and 39, while in grades of ACLF, it was 57, 33, and 25. And adverse effects to terlipressin was 6.7% in decompensated cirrhosis group, while it was 17.3% in the ACLF group. And predictors of treatment response in our CLD group was serum creatinine, CIRS at baseline, rise in mean arterial pressure more than 5 mm by day 3, and a reduction in the renal resistive index more than 5% by day 3. While in ACLF group, it was, as already mentioned, bilirubin, creatinine, MELD score, and ARC score. And the need for RRT was 13% in CLD, while it was 38% in ACLF. 30-day mortality in CLD group was 15%, while in ACLF it was 45%, and 90-day it was 35% in CLD, but 74% in the ACLF group. And predictors of mortality was same in both groups. Non-responsive treatment was an independent predictor of mortality in both CLD and ACLF. And this was the Kaplan-Meier curves. So coming to the discussion, the response to terlipressin is poor in ACLF patients as compared to decompensated cirrhosis, probably due to the different mechanisms of renal failure in ACLF patients. In patients with decompensated cirrhosis, the AKI is predominantly functional due to renal hypoperfusion, which is caused by the splanchnic vasodilatation. However, in ACLF, it is the exaggerated systemic inflammatory response which plays the major factor in the pathogenesis of renal failure. And ACLF patients also have a high bilirubin and profound cholestasis, which will further impair the renal function by worsening the systemic inflammation and leading to direct tubular damage. So, urinary elimination of toxic bile acids can cause what is known as cholinergic nephropathy, which has been shown to cause histologic kidney damage in animal models as early as around 3 weeks. So, in ACLF, there is probably an additional structural component of AKI in addition to the functional AKI in decompensated cirrhosis, which probably leads to the poor treatment response. And our limitations also, it was a study conducted from a single center, and the duration of follow-up was 3 months. In the future, multi-center studies are required with a larger sample size and longer duration of follow-up. And the addition of urinary and serum biomarkers could help to better differentiate different types of kidney injury and individualize treatment decisions. So to conclude, the rates of response to vasoconstrictor therapy in ACLF is significantly lower as compared to decompensated cirrhotics. As the grade of ACLF advances, HRS tends to be more progressive, and hence there is a more poor response to telepresent treatment. And treatment non-responders have a higher mortality and should be fast-tracked for transplantation. Thank you.
Yeah, thank you, Dr. Vijay. How many patients had SBP in your group?
SBP was in our decompensated cirrhosis group. SBP was, but in ACLF.
In ACLF.
SBP was very less. Infections as a precipitating factor was ACLF was in around 19%. 19.
So see, this is a major problem in these patients with ACLF. If you start the vasopressor, terlipressin, then their MAP is low, although we are justified, but they don't tolerate. And that is the reason why the adverse events are very high, 20% roughly.
17%.
And on the other hand, if you look at the decompensated cirrhosis in your data itself, this is only 6%. So this is a major problem in these patients. In how many patients you could increase the dose? This was an infusion only?
Infusion.
2 mg?
2 mg infusion.
So how frequently you increased, and then in how many you had to increase to get the response?
We increased after 2 days. If there was after 48 hours, if there was no response, we increased the dose, sir. In ACLF, what we actually noted was that in patients who actually responded, the dose of telepressin required was less in ACLF as compared to CLD. In CLD, we could increase up to 6 mg, but in ACLF, those who responded
Don't talk of CLD. Don't talk of CLD. Talk of your study.
ACLF, those who responded to doses at 2 or maximum to 4, not more than that, sir.
Many of these patients, the CVP is quite high when they come with the ACLF.
Yes.
And in that, how many you could not give albumin?
Albumin, sir, a few patients we could not give, sir, but I don't exactly remember the number, but a few patients
Then there is a mismatch.
we could not.
If you could not give albumin in some of these patients, then this is a mismatch.
They were not included in our study, sir.
They were not included.
We include only patients who did not respond to albumin and who are offered telepressin. Only those patients were included. Those who did not respond to albumin and those who were not offered albumin were not included in our studies.
Okay.
So around 47% did not respond, and of that around 20% had complications.
Yes.
So the issue was patients who did not respond, did they have higher creatinine at baseline? They had higher MELD overall. MELD is an indirect reflection.
Yes, sir.
But were they more sicker than patients who responded?
They were not essentially more sicker, sir, but the creatinine was slightly higher because creatinine was also an independent predictor of treatment response. So creatinine was slightly higher in non-responders, and the AKA stage at baseline was also higher.
What was the etiology in your patients?
Yeah.
How many had sepsis? How many had alcohol?
Predominant etiology was alcoholic hepatitis, ma'am. In around
Agreed. So in that category, the ACLF 1, 2 and 3, any relationship of the etiology versus the cause?
etiology was not found to be significant, ma'am. That's why I didn't project it. Etiology, the predominant etiology for ACLF.
Sepsis?
Predominant was alcoholic hepatitis in 47%, and infections and sepsis was in 19%, ma'am. 19. That was the.
But did you look into that aspect of the response to terlipressin and albumin?
Yes, ma'am. But it was in ACLF. It was not found to be significant.
It was not shown in your slides.
Yes, ma'am. We had been asked to limit the slides to a specific number, so I could not
The
include.
demography could have had the etiology. I think it's a very important component for your.
Yeah.
Sir, patients with ACLF 3, I think, responded poorly to telepressin. They were sicker patients, sir was asking.
ACLF 3 had only 25% complete response.
Response was poor, no?
Yes.
This study, the albumin was not used.
This was
Only
used.
telepressin.
No, sir. Albumin was used initially, and then telepressin plus albumin, sir. Both combination. So dose of albumin, we could use only 20 gram per day dose, sir. The initial for some patients we could not use the 40 gram dose. We could use only the 20 gram per day dose because patients were only tolerating that dose. So we could use only that dose. SBP was
How many had SBP coexisting with AKI?
19%. I had infection.
No, SBP.
SBP was in that was total infections was 19. SBP was in around 13%, 13% had SBP.
So antibiotic was also.
Yes, ma'am. SBP was.
How did you rule out infection?
We
Predominant alcoholic hepatitis.
yes, yes, yes.
Hemodynamic infection was only 19%.
Yes.
How did you rule out?
Alcoholic hepatitis, we had done a CRP and ProCare, so that's all what we could do. And cultures were sent, but by the time cultures were available, we had already started treatments.
Okay. Any other question or comment? Dr. Paulo, you want to say something?
I only want to congratulate because you confirm our data that we published 2 years ago
Thank you, sir.
in patients with ACLF according to the INASL criteria. So these are different criteria, but the results are the same. Unfortunately, you don't have an urinary angle
Yes, sir.
to support some of your conclusion, but I totally agree with you. Congratulations
Thank you,
again.
sir. Thank you, sir.
Thank you. Thank you, Dr. Vijay.
Thank you.
Yeah, now we'll have the case discussion and it will be by Dr. Gaurav. So, Dr. Paulo, please come here. We'll sit here. Seema is not here. Then Dr. Divya, yeah, please come. Then Dr. Gyana Ranjan Raut, he is also not here. Okay. And then Dr. Kanu Charan Das, yeah, please come here. There are enough seats here, he can come. Divya, you please come here. This is a mix of moderator, panelists and, okay, chairpersons. Gaurav, please go ahead.
Yeah, so we'll start the case. This is one of the tougher cases that we have. It's again an ACLF patient with ascites mobilization. So, presenting a 40-year-old gentleman, a young gentleman, ethanol abuse, moderate ascites, was initially well controlled on diuretics, but progressively with increased alcohol intake and duration, he required regular LVPs. So, February 22, progressive increase in ascites requiring LVP, maximized the dose of diuretics, developed recurrent hyponatremia. Sodium was from 108 to 116. So it was more of a diuretic intractable ascites. He developed hepatic encephalopathy and hyponatremia. So again from Feb to July 22, continued alcohol abuse. July he came with progressive jaundice, tense ascites, pedal edema, left lower limb cellulitis, fever with dyspnea. He had oliguria for last 5 days and altered sensorium. So looks like a patient with tense ascites, probably infection going into HRS, has oliguria and altered sensorium. No other decompensation in form of hematemesis or no other significant comorbidities like diabetes, hypertension. General physical examination, the main issue was MAP was low, MAP was 68, had severe pallor, deep icterus, tense ascites. So obviously this patient was on multiple antibiotics outside before he came to SGPGI. So that was again a risk factor that we were dealing in this patient. Baseline investigations, hemoglobin was 6, platelets 28, INR 2.83, OTPT was 2:1 ratio was followed, OT 160, SGPT was 57, albumin was 2.5, bilirubin was again high, bilirubin was 36. Ascitic fluid, he was already on antibiotics, but still was neutrophil predominant, fulfilled the criteria for SBP. Viral markers were negative. HVPG was 18, was done 2 months back in a different center, and he had come with HVPG report. We had not done a repeated HVPG at our center. We normally do hemodynamics to assess the hemodynamic gap or deficit that is there and how bad is the hemodynamic for this patient. Heart rate tachycardia was there, MAP was 68, cardiac output was very high, SVR was low, very low, 668. Other markers, stroke volume and SVI was on the higher side. Renal artery resistive index was 0.8, so there was severe renal vasoconstriction, and he was filled up. CVP was 18. So in a nutshell, probably was ACLFC, alcohol on alcohol, high MELD, high Madry's index with 2 to 3 organ failure, as yet fluctuating hepatic encephalopathy between 2 to 3. So therapeutic challenges that and he was already on beta blockers from outside. He had tensitis, organ failure, anemia, hyponatremia, AKI. Creatinine was 2.8, poor liver functions. In our center, we started on imipenem and tigecycline and albumin with terlipressin. Assessment, MAP was low, renal artery disease index was very high, CVP was 18, PRA 24. Urine sodium was single digit, creatinine 2.8. SBP was present. So a mix of multiple problems that this gentleman has come with. So Professor Paulo Angeli sir, may we start with you. So this patient has AKI, how do we grade and stage AKI? What's the type of AKI that he may have had?
Just 1 minute before Dr. Paulo takes the questions. There are few problems in these cases. See, the dose of the diuretic, as per the guidelines, the ratio should be 40:100. And on the other hand, it was 80:100. See, and that is one reason the high dose of furosemide has led to the hyponatremia. And this patient is fluid overloaded, and because he is not losing sodium, and that is the reason why there is a pedal edema, and the CVP is 18. You cannot give the albumin in such a patient. You said the albumin and terlipressin were given.
Just recap
So,
that.
and majority of these patients, if you come across a MAP is low, there is a hyponatremia, even if I don't do a diagnostic tap, this is 90% patients, these patients will have SBP, which was there in this patient. So these are few problems which are to be noted down. Yeah, Dr. Paulo.
Yeah, I fully agree on the origin of hyponatremia related to the high dose of furosemide as compared to the dose of spironolactone. What type of AKI? Well, the patient has an ACLF with 3 or 4 organ fail, has an infection, has a very low urinary sodium excretion, no evidence of proteinuria, no evidence of hematuria. So according to our criteria, the patient has an HRS AKI. Which stage? We have not a baseline serum creatinine, but probably serum creatinine was normal. So we are speaking about a stage 3 AKI. And as we learned just from one of the abstracts, in this patient, the response rate to terlipressin plus albumin is less than 30%, 25% probably. So I will start immediately with terlipressin plus albumin, and then we will see,
Right, sir. So what about beta blockers, sir? Patient was on beta blockers. Would you like to continue beta blockers or stop it now?
I will stop him immediately because we have 3 major contraindications: AKI, infection, and hypotension.
So though BP was normal, MAP was 68. So MAP 68 definitely merits to stop beta blockers. It's very, very important actually. So though beta blockers has multiple advantages in DCLD, but in ACLF with MAP less than 68, still it's good to stop immediately, as Paulo sir said. So the window closes for beta blockers, especially in ACLF with MAP less than 80, AKI HRS.
There is a comment from the expert here.
One thing that in the SBP, we have to give albumin. There is a
I will come to the SBP question further. We are coming to that. We are coming to the SBP questions further. So the window closes for beta blockers as MAP decreases, AKI sets in, PICD sets in, and in presence of sepsis and infection. So definite clear-cut issues that this patient required immediate stoppage of beta blockers, and that was done. HVPG high, he had HVPG of 18 2 months back, sir. Though it was not repeated. Should we look at HVPG, or we assume that in ACLF again it's high and probably it makes ascites mobilization more difficult here?
I don't think we need to measure HVP in this patient. By definition, this patient has portal hypertension. So it doesn't matter if HVPG is 12, 15, or 25 millimeters of mercury. We should treat the complication because the probability of die is around 70% at 28 days, So I will not lose time to measure HVPG. I don't know the other actor.
I fully agree. There is no
Yeah, that's
point
absolutely
in
true. So
asking
it's-
for a HBPG in such a situation.
ACLF do not require HVPG measurements. Studies, though, from ILBS have shown they have high HVPG. The problem is with high HVPG, if it's high, the portal blood flow decreases. So circulation and renal blood flow further comes down in these patients, even if we don't measure. So coming to hyponatremia, Professor Singh, how do we tackle hyponatremia? How do we approach hyponatremia in this patient? And is there any role of any other medicines?
See, this hyponatremia in this patient is because the overdose of the furosemide. So, and if we correct it, this patient is already fluid overloaded. So, and there is another reason, there is SBP. So all three contribute to the development of hyponatremia. So you take care of the infection and then you take care of the fluid overload, then this patient will, the hyponatremia will automatically improve.
So patient is sick, he started on antibiotics, he has fluctuating hepatic encephalopathy. Apart from fluid restrictions, would you consider 3% saline or would we just wait?
In such a patient, there is no point in asking for the 3% saline. See, this patient will improve once you treat SBP. Okay.
Any role of addition of tolvaptan here? Yeah.
Tolvaptan in such a situation is, see, this is deleterious here. See, the AKI is there and then you should think of the patient overall. The SBP is there. You cannot use tolvaptan in such a patient.
So absolutely very important point, hospitalized admission, hepatic encephalopathy with AKI, tolvaptan should not be used.
Sir, for hyponatremia, can't we use this albumin load, maybe slowly, very slowly, with low dose of diuretics? Can you try that? Very low dose. Albumin will take care of SBP and may correct hyponatremia also.
That will increase the survivability of the SBP. That's it.
So SVP, we are coming to next question again, is it?
That will increase the survivability.
See, I understand. See, here we are not worried for the development of AKI. This patient is already having AKI. The albumin is given for the prevention of the further AKI. First, you let us treat the SBP because this patient is fluid overloaded. If you further give albumin, he'll go into the failure and he will die.
Sir, my concern is that-
This is, I know the albumin is very important part of the treatment of SBP, but not in such a patient where this is fluid overloaded.
So baseline, that is the TLC value of ascites, if it is high, and after 48 hours antibiotics, if that is in a decreasing trend, why not we will start albumin? Because albumin itself is anti-inflammatory property. It has an anti-inflammatory property. It is a good vasoconstrictor besides the plasma expander.
Yeah,
So it will improve that
Yeah.
kidney, renal profiles.
The only reason we have to start immediately albumin plus terlipressin to avoid the load of albumin is that this patient is very, very sick. We cannot wait for 48 hours to see if it will respond to albumin or not. In addition, I'm very confident that during treatment with terlipressin plus albumin, we will correct hyponatremia.
Absolutely, very, very important points. Both albumin and terlipressin should be, we use that regularly. And obviously albumin itself has sodium. So albumin,
Normally, if we look at the side effects of terlipressin, hyponatremia is one of the side effects. But here, not here.
not here.
See, here, this is, if you give terlipressin in this patient, the MAP will improve, this whole cycle is reversed, then the
The
hyponatremia
circulation
will
improves.
improve.
And the problem is papers with terlipressin had a very high dose of terlipressin, not at 2 mg per hour continuous, 2 mg per 24-hour continuous infusion. So those things are very important, sir.
So
follow, sir.
just a sec. So any level of sodium where you will consider 3% NS, or that is not a 110, say lower than that?
See,
Not a consideration.
there is no point in talking the correction of the hyponatremia with 3%, unless this is a patient who is planned for the liver transplant and you want a very fast correction of the hyponatremia. Otherwise, if you give the 3% NaCl, this patient will be further the fluid overloaded, and so this will be a problem. So do not think of starting follow the other measures. Here the cause is very clear. This was because the overdose of furosemide and the SBP. So you correct that, it will come back.
Yeah, so basically studies have shown that if MAP is more than 82, if you get the MAP more than 82, the circulation improves. The renal artery resistance index and all those things that we have further done comes down, PRA comes down, the GFR improves. So higher chance that the therapy and probably diuretics also may act there. We just come to that. So Professor Paulo Angeli sir, dose of albumin you mentioned is important here. What dose of albumin? It is 1.5 gram per kg day 1, or you may consider lower dose in such a situation?
You know, the doses are based on only one controlled clinical trial with a relatively small cohort of patients. But after this, the conclusion entered into the guidelines. So I think that we can modulate the dose and also the way to infuse albumin in patients with SBP according to the volume status.
Absolutely.
As he said, in this patient there is no evidence of volume depletion. So I will be more prudent in this type of patient.
Absolutely. It's not a fixed dose of 1.5 gram per kg.
Yeah, 1.5 is as per the guidelines on the first day, and then on third day it is 1 mg, 1 gram. And so if you look at the guidelines, parcel guidelines which we publish, in that we mentioned that there are studies in which they have used the lower dose of albumin. So we are justified in giving the lower dose.
Right. So albumin infusion has shown to improve the outcome of SBP and is again prudent. The dose varies depending upon the patient tolerability. It's not fixed as at 1.5 gram per kg. As Professor Paulo Angeli has said, it has multiple other advantages, antibiotics with albumin. Now, is this SBP difficult to treat SBP? Patient has had multiple hospitalizations. He has been on IV antibiotics. We have started imipenem. Now, how to go about? Initially, do we think or assume it's difficult to treat SBP, or there are multiple other markers that you go ahead with, sir? And do you similarly change your antibiotic initialization when this patient comes to IP?
Well, I speak about our experience in our unit according to the bacteria resistance we have in our unit. This is important to know what do you have in your unit. So in this type of patient with an hospital acquired SBP, I will start immediately with carbapenem plus daptomycin, just to cover most of gram negative and also difficult to treat gram positive. I mean, vancomycin resistant enterococci, methicillin resistant staphylococcus aureus. This is what we do in our unit according to our platform of bacterial resistance.
It's very important because time is prudent here. Very, very important to hit hard hit initially. Can't go on waiting 48 hours to...
Gaurav, what was the culture report here?
Yeah, so culture, we no bacteria was grown in this patient.
But it is not given here.
No, so actually I mentioned cultures were strike in the things like.
And it is important to do also a rectal swab to see if there is a colonization by extensively drug-resistant bacteria in this type of patient.
It's very important. We also miss rectal swab culture here, and it should be done routinely, as has been mentioned by Professor Paulo Angeli. So it was a difficult to treat SBP, multi-drug resistant, repeated hospitalization, multiple antibiotics, refractory ascites, ACLF with AKI, multiple predictors. So we have to consider MDR, non-NXDR variants that might be there. So initial choice of antibiotics should be considered, taken into ESBL, fluoroquinolone resistance, MRSA and VRE. So this is the treatment guideline that has been mentioned. As Professor Paulo Angeli sir said, carbapenems plus daptomycin. All this combination has to be thought as a first line and nothing else. Too, because initially time is prudent here. Patient is already very sick. Have to get antibiotics to treat his. Yeah, so basically linezolid is what we use. That's what we had mentioned here. But this is the treatment protocol that we had. Now, any role of GCSF, GMCSF, sir, on study from India, Professor Singh?
See, in one study, Dr. Sareen showed the usefulness of this, especially in a difficult to treat SBP, but I don't have any experience with this.
You have been using GMCSF a lot. So this patient,
I have not been using GMCSF, I have been using GCSF.
GCSF.
So-
Although in both of these cases, TLC goes up. And once TLC goes up in the setting, it's very difficult to differentiate that sepsis has progressed because alcoholic hepatitis with alcoholic ACLF. Patient may have fever, may have high counts, may have high CRP, high ESR, inflammatory markers would be high. So what is your level of threshold to decide that we might be requiring to change antibiotics or resend the cultures?
See,
on such a
I have
scenario?
seen many times if we give the GCSF in these patients, I'm talking of the decompensated cirrhotics. Many times the patient is not improving. The bilirubin is going up. So this is the time probably this patient is going into sepsis. Then we look at the ascitic fluid and then see the count. GCSF increases the counts otherwise, but if this is corroborating with the clinical picture of the sepsis, then we hike up the antibiotic.
So how do you say sepsis here? He might be having tachycardia, respiratory rate might be high, CRP, all these inflammatory markers to say sepsis, search criteria may be fulfilled just with severe alcoholic hepatitis.
It is very difficult to differentiate, and apart from these cultures and all, we should also take help of the CRP and the Procal, but nothing helps in such a situation. This is the clinical impression only, and you have to start the better antibiotic in such patients.
Yeah. So medical treatment, any options for TIPS? Though TIPS is better than paracentesis, but patient is too sick for TIPS. Probably the higher the value of bilirubin, lower the sodium, the lesser the survival on TIPS that these patients have. Role of RRT, does he require RRT, Professor Paulo sir? Does the patient merit RRT? If RRT, early versus late, and which modality of RRT?
Well, the decision about RRT, if the patient will not respond to the treatment with telepressin plus albumin, is a very difficult decision because we are dealing with the patient with the 4-organ failure. So the mortality related to RRT, as we learned from one of the abstract, is up to 80%. So I think we can propose RRT if the patient is a candidate to liver transplant, and then to perform it as early as possible after we check that the patient is a non-responder to telepressin plus albumin. And the modality should be, of course, a very, very low rate of plasma exchange because this patient has an impaired systemic hemodynamics. So the risk of hypotension related to RRT is quite high.
Very nice. So 48 hours response to telepressin should be good enough to consider, or 96 hours or higher?
48 hours is very short because you can check only one dose. I will check at least 2 doses, 2 milligrams and 4 milligrams of telepressin, because we know that almost 90% of patients will respond to a dose lower than 4 milligrams per day. So I think that probably 72, 96 hours may be better, you know,
Right.
but no more than this.
Just one clarification, Dr. Paulo. What is your the protocol? You after 3 days, after 48 hours, you increase the dose to double it, means the 4 mg, or you make it 3 mg?
No, we usually start with 2 milligrams. Then we go to 4, to 6, to 8, but it is very, very, very uncommon to go beyond 4 milligrams per day to get the response.
Absolutely agree.
In such patients, when especially ACLF and the SBP, they don't tolerate a high dose. I've seen many times, you start with the telepressin and with the 2 mg itself, they will start having diarrhea. And in that case, what you do, you can decrease the dose of telepressin or delay it for maybe another maybe 24 hours, and by that time the effect of antibiotic comes, and then you can increase the dose to 2 mg, and then they tolerate. So in the presence of SBP, they usually may not tolerate. So if they are not tolerating, start with the lower dose. After 48 hours, when the effect of antibiotic comes, you can make it a 2 mg dose.
So anyway, potential benefits of RRTs.
Sir, two things, sir. One is use of linezolid. Linezolid is a good antibiotic for SBP. The first thing, and it causes cytopenia, thrombocytopenia. Already, that is.
So
one
this patient did not have, his counts were all right initially. With alcoholic hepatitis, counts were especially on the higher side. With the available antibiotics that we had as the first line, we assume it's a multi-drug, it might be a multi-drug resistant, difficult to treat SBP at the first go, looking at the patient profile. Patient may or may not have that, but assumption and starting first line antibiotic recommended was what we did in these patients. If the patient comes from home, it's all right. He doesn't have multiple risk factors. He might have SBP, and treatment protocol for antibiotic might be different there.
Then, sir, role of exchange plasma, maybe such high bilirubin that will.
So role of, as Professor Paulo sir, would you like to take that? Plasma exchange instead of RRT to start because of severe.
Yeah, we are performing a trial comparing plasma exchange using albumin in the solution versus the standard medical care, but we have not still data on this.
So data is emerging. Potential role of RRT, if at all, is early. It enables rapid control of metabolic abnormalities and acid-base status, limits progressive volume overload, supports multi-organ dysfunction, removes toxic low and middle level molecular weight substance. The issue is cost and complications are there. So what is the current evidence based on RCTs? So RCTs, 620 patients, RCT, CTP-C cirrhosis, early versus late, there was no difference. Second RCT with 231 patients did suggest that early initiation reduced the 90-day mortality. But latest RCT with 488 patients suggested there was no difference and was terminated early. It was the RCT to suggest early versus late use of RRT. So how does it translate to liver ICU? Almost no literature, as has been mentioned by Professor Paulo Anjali sir. Hardly any literature is available in liver ICUs to go around this. This slide, Dr. Rakhi had to come there, but she shared this slide of which modality. So at ILBS, this was the paper submitted by Dr. Rakhi at ASLD. They suggest that SLED was slightly superior to CRRT. SLED was slightly superior to CRRT, as plus this abstract that was presented. Now again, Professor Saraswat had to join and Professor Saraswat didn't come, so these questions were there for sir. This were the few things that we were doing at our center. So role of albumin, vasoconstrictors, correction of MAP, and role of diuretics if any. So this is the pathogenesis that is there. The important players are decreased effective arterial blood volume. So albumin and terlipressin both are used to increase the effective arterial blood volume, get the renal perfusion right, and reduce bacterial infection. Now there is gut congestion that would lead to obviously impair the tight junctions getting loose, bacterial translocation, and obviously it leads to SBP and further infection that is there. So fluid mobilization has never been a very important target of treating patients with large ascites and ACLF. Albumin and terlipressin improve the volume, but aside furosemide has not been very commonly used. If used, it's been oral furosemide, oral diuretic that patients with large ascites tolerate. Basically, it is an effective arterial blood volume deficit. The deficit varies because of portal hypertension, splanchnic, and systemic vasodilatation. Albumin level might be low. This deficit may vary from patient to patient. Some patient may have a very small level of deficit. Some patient may have a very large level of deficit. No two patients with large ascites will have the same level of deficit. The main issue is to correct this deficit with vasoconstrictors albumin, and once the deficit is getting corrected, mobilize the fluid. So the three important issues are splanchnic vasodilatation, hypoalbuminemia, and systemic vasodilatation, and we have the drugs used to treat that. Initially in this patient, we saw that SVR was very low. That can again be tackled with terlipressin alone, but higher dose of terlipressin these patients do not tolerate. So a combination of low dose NORAD with terlipressin probably his time is up, may help reduce the complications. I'll just try to finish up fast. So what we aim is to get the renal artery density index corrected to less than 0.7, get the MAP up. And with diuretics, urine sodium improves. So this is the trial that we did in ACLF patients with AKI, around 287 patients. We had a response to the tune of mobilization of ascites to the tune of 87%. And patient who had urine sodium crossing 80 within initial week, they did much better and survived. The survival was almost to the tune of 70% than patients who did not achieve urine sodium. Patients not achieving urinary sodium tells me that they have severely deranged hemodynamics. The effective arterial blood volume deficit is very, very high. And obviously with this, they also improved since we mobilized the fluid by addition of furosemide, so gut permeability also came down. So we did the regular monitoring, urine sodium went up, then we started furosemide infusion with low dose NORAD. Again, urine sodium kept on increasing. Suddenly on day 8, there was a dip. Once you have this dip, again suspect there might be a secondary infection that the patient might have acquired in the hospital. We looked at it, patient had an UTI. Again, antibiotics were altered based on culture. Urine output started improving again, creatinine again steadily started decreasing, MAP improved. Hemodynamics improved and renal permeability improved. Now this patient did well, had a TGLB, came out alcoholic hepatitis. Once the ascites was mobilized, hemodynamics controlled, then he was started on steroids. It was almost at the week 2, and his bilirubin had come down at 1 month to 2.4. MAP had improved, most of the parameters had improved. So at 30 days, CTP had come down, MELD had improved, MAP had gone up, CVP had come down because of fluid mobilization, urine sodium had improved. Now at follow-up, again he has come with reappearance of ascites, though he is salt compliant. Again, he went to the local doctor, furosemide was hiked to the same dose initially. He was started at 40, went to the local doctor, ascites was not mobilizing, again furosemide was hiked. As has been mentioned by Professor Singh, the ratio was not correct. So serum sodium had also come down to 126. Now, sir, what next? The last question.
One thing is very important. You should teach your local doctors. They should follow the certain rules. Do not give the furosemide in a high dose. Again, this patient will come to you, and the fluid overloaded with the hyponatremia, the AKI. So this is a major problem.
So now, should we consider tips? Oral vasoconstrictors, do they have a role? Patient is not affording transplant. Most of the Indian patients, more than 90% don't afford a transplant because of various reasons. So transplant is definitely not an option for him. Now, how to go about? Is there any role of oral vasoconstrictors like midodrine here, or should he be planning for tips here? Follow, sir.
Well, first of all, I will say that this patient was very lucky, because it is unusual to say an outcome like this in a patient with ACLF grade 3 and 4 organ failure. Usually we go towards an early transplant. But this patient was very lucky. So I think that at this point, I will adjust the ratio between furosemide and spironolactone, and I will propose him for a long-term use of albumin. And that's it.
So much.
That's it. I fully agree with Dr. Paulo.
Any role of midodrine oral vasoconstrictors here, sir?
Why should we use midodrine? This patient will respond if you correct the ratio of furosemide and the aldactone. This patient is likely to respond, and the salt restriction will respond to diuretics only.
Sir, this severe ACLF using corticosteroid, is it a correction?
So this was started at the end of second week. Once most of the hemodynamic correction was done, some infection was controlled.
Patient having UTI, sir, it is
no, that was on day 8 actually. That was again controlled. We actually started at end of second week, so day 14. You correct the hemodynamics, correct what all correctable factors are there, and then you may consider if the patient is not improving. Now, most of the patients don't afford transplant and we have very limited options with these patients.
Sir, because we have seen that after 3 or 4 organ failure, patient having UTI, another.
Yeah, so all these organ failures were improving. We had got the creatinine down. He had improved from hepatic encephalopathy.
The corticosteroid was given when the patient was already improving.
Still
so don't know whether it is because the corticosteroid or
when still
We usually don't start these patients on the
Sorry,
corticosteroid.
in common practice, actually, if you are giving corticosteroid after having 4 organ failure, having UT.
Yeah, so these
practically
patients
speaking,
were improving at the end of second week. Biopsy was showing significant inflammation. If biopsy was showing significant fibrosis, it's very difficult to initiate albumin. Vice versa, biopsy was showing significant inflammation. AKI had improved, HE had improved. The patient had high bilirubin, cholestasis was persisting, infections were taken care of. Only then, at the end of second week, was a low dose steroid added.
Any other question from, yeah, please.
Can you use the micro, please, because we cannot get your.
How do you monitor for the hemodynamic status in such sick patients? Like, is there any role of continued intravascular volume determination or something which will play a role? And do you use 5% albumin in any circumstance where they come with a shock-like picture, septic shock, where they have fluid overload and the chest is congested? Is there any role of 5% albumin, and what is the modality of hemodynamic monitoring that you use in these patients?
If the patient is on a regular ward, we use non-invasive modality,
Yes.
such as, for example, monitoring the cardiac output, monitoring the intra-abdominal pressure, and that's it. If the patient is in ICU, you will require invasive monitoring of systemic hemodynamics. This is what we do routinely.
But non-invasive.
Non-invasive, yeah.
Your cardiac output and ultrasound Doppler are good actually. Getting an SVR, getting a renal artery resistive index, IVC filling, all these really help in monitoring these patients.
So, is CVP is a good modality, especially with ascites?
No, it is not.
So still we are following that. We are telling that it is fully overload.
What about 5%?
We don't usually follow the CVP. We measure the IVC dia. That is a little better.
So IVC and RARI were the
Yeah.
That is also not reliable. I think IVC diameter is also.
Yeah, but it's very difficult to do invasive monitoring in these patients. They may have INR prolonged, can't give FFPs regularly. You have surrogate markers, So these, and you are giving vasoconstrictors. So you have to look at the response. You may have improvement in RARI, urine sodium, fluid mobilization.
So what
So
about
indirect-
5% albumin? Sorry.
So question is, what about 5% albumin over 20% albumin?
See, there is no point in giving the 5% albumin. This patient is having AKI. We'll have to give him the 20% albumin.
Volume, effective arterial blood volume has to be maintained.
So 5% albumin available in a 250
Some
ml.
role of a septic.
Instead of 100 ml in 20%.
So the issue is, normally once you start, it's very difficult. It's almost as follows, sir said, we are not giving 1.5 gram per kg. How much are we giving? Are we giving 1? We are not giving 1 gram per kg also. So we give 20 grams, and basically clinically his tachypnea has not worsened, basal crepes have not come back, he is tolerating 20 gram. There is significant or the trend is towards improvement of hemodynamics. Then next day, because albumin has to be given slowly, we give albumin slowly over 10 to 12 hours. We don't give within 2 to 3 hours. We give one bottle, 100 ml has to be given over 12 hours as far as our center is concerned.
12 hours is too long a period. Gaurav,
So continuous
if we give a 20% albumin, the one bottle of 100 ml over 12 hours,
Yeah, so now we said we
then
don't exceed 40 grams per day actually.
no, 40 grams per day means the whole 24 hours the albumin is running.
It's almost a continuous infusion. For us, it prevents complications like pulmonary edema and fluid overload.
We have very well given in the apostle guidelines which has come up. Usually we should follow maybe 3 to 4 hours, not more than that, and not faster than that.
Yeah, so basically, we use furosemide with that. So it's almost a continuous albumin furosemide infusion. Problem is furosemide will not act because in ACLF, albumin is oxidized. It's almost dysfunctional. If furosemide is not attached to albumin, more than 95% furosemide is attached to albumin. So if it's not attached, furosemide is not going to act.
Gaurav, can we discuss it later?
Right.
Any other burning question from the audience? If none, then thank you very much.
Thank you, sir.
Thank you, chairperson, speakers, and panelists. Now we will have next session here in Hall 3 on hepatology physician at 11:15. Thank you.
So a very good morning to everybody, respected faculties, delegates. So this is the 31st annual meeting of Indian National Association for Study of Liver. So we are very fortunate that Odisha is hosting the meeting here at Bhubaneswar. So today is the last day. So what are the additional things we have done? I'll just tell you in a few seconds, maybe 1 or 2 minutes. So one is CSR activities through INASL. One is we try to reach the society, like we did an awareness campaign, workshop for the police people, police personnel, more than 400 police personnel that joined here. So under the INASL banner, we just created awareness among them. More than 400 school children, they joined here. We took care of them. And more than 300 senior citizens joined here also. So this meeting we thought of, we dreamed maybe 2 years back. So this meeting is under the guidance of Professor S.P. Singh, who is the President INASL, and with me and my good friends Dr. Sushant Sethi, Dr. Manas Panigrahi, who are the Joint Organizing Secretary. Dr. Devanand is here, the complete G20 team and the local organizing committee. So we need to start the physician meeting. So we all are physicians. So some respected physicians are on the way, they are just joining, but we thought let's start some time. Now request, please start. Thank you very much. We are extremely grateful that all the physicians are here. Today is Sunday, so we get one Sunday in every week. Today is Sunday. In spite of that, we are having physicians here. So Dr. Devanand and Dr. Manoj Chatrai sir, they are taking you through the physician program. Thank you very much.
So now we are starting our session, Hepatology for Physicians. The course directors are Dr. Devanand Mahapatra sir, Dr. M.K. Chotray sir and Dr. Jayant Panda. So the first topic is approach to a patient with raised transaminases. For this, I would like to invite on stage our chairpersons, Dr. Sabyasachi Patnaik, Dr. Sambit Behra, Dr. Dilip Kumar Mahanti and Dr. Rajat Khandalwal. Please come onto the dais.
Good morning, respected faculties and our physicians. I would like to thank Dr. Manoj sir for giving me an opportunity to be among you all. I would like to thank INASL, Dr. Singh as the president and the organizing secretary, Dr. Manoj. This is a unique program for physicians basically to understand how we are running with the liver disease. There are different topics. I would like to invite Dr. Chotray to the stage, who is the course director, to speak few words and we can start.
Good morning. Well, while I express my gratitude to the organizers, Dr. Manoj sir and Dr. S.P. Singh and Dr. Sethi, they have entrusted us as course director for this positions meet. We have selected 3 good subjects: raised transaminase and every fatty liver, and the other thing, which are very important for physicians, because it is Sunday and last day. We are seeing thin audience, but I think in the course of time they all will come. I hope you will all enjoy the subjects, and without delay, I'll ask the chairpersons to start the meeting. Okay, thank you.
Thank you, Dr. Mahapatra and Dr. Chotra, Manoj Bhai. And at the outset, let us congratulate the Dr. Misra, Dr. Sahu and the team, INASL 23 for a grand conference, I think. As Dr. Sahu has said, the special programs for the police personnel, the children and the physicians. Thank you, Dr. Sahu, for a wonderful event.
So another thing we brought this time, the Go Green.
Yes, Go Green, yes. So, yes, that's also first time in any conference. Thank you, team INASL 23 for that. Without wasting more time, we are all physicians primarily. And in our clinical practice, we always find patients with coming with a report of raised transaminase, and the person is very much worried. So, to clear the conception, or to have the conception, we invite Dr. Sudhanshu to talk on approach to a patient with raised transaminase. Dr. Sudhanshu, please. I request the speakers to speak on to stick to time. Dr. Sudhanshu, please.
Good morning, all. I would like to thank Professor S.P. Singh, Professor Duseza and Professor Manoj Sahu for this opportunity to talk in this August gathering. Today, I'm going to talk about approach to a patient with raised transaminase. I bring greetings from Nepal and Nepalese Association for the Studies of Liver. This will be my outline of the talk. So every day, we happen to see a case or two where patient comes with elevated liver function test, and among those, liver enzymes are the most important test, and this evaluation of elevated liver enzymes in patient presenting with no symptoms sometimes can be very challenging to every physician. And although the elevation of liver enzyme may be the first clue of liver disease, we should know that normal liver enzyme do not negate the significant liver disease. So among all batteries of liver function test, aminotransferase are the 2 most important enzymes, and these enzymes catalyze the interconversion of amino acid and oxo acid by transfer of amino groups, and it participates in both protein metabolism and gluconeogenesis. We have 2 important enzymes. One is ALT, also commonly and widely known as SGPT, and another one is AST, or asparated aminotransferase, commonly known as SGOT. We still hear from our senior that what is the OTPT of the patient. So this is still commonly used. Now this ALT and AST both are present in hepatocytes, and AST is also present in significant amount in non-hepatic tissue like cardiac muscles and skeletal muscles. So the test can be abnormal in both liver disease as well as non-liver disease. The primary clinical application of this raised transaminase is to detect and then have the differential diagnosis of different hepatic diseases. Elevated liver enzymes means hepatic cell injury, and sometimes these enzymes appear before the clinical symptoms appear. And in most of the cases of liver diseases, ALT are most specific, but AST is very important in case of condition like alcoholic hepatitis and autoimmune hepatitis. This ALT consists of 496 amino acids, and it has a half-life of 47 plus minus 10 hours, and it has diurnal variation. The minimum activity is seen at 4 a.m. and maximum activity is seen at 4 p.m. So we should sometimes take we should take sometimes consideration of the timing of the measurement also. Ethnicity has also some role. Mexican Americans, they have high ALT level. Men have more ALT than female, and then this ALT is also directly associated with BMI, and most probable cause can be the liver fat in the liver. So this normal level of ALT is sometimes very confusing because there are many societies and many labs which give different levels. But as per AASLD guideline, less than 30 is standard for the male and less than 25 for the female. In Europe, they have considered 40 as the cutoff level for the normal ALT, and INASL has taken 40 instead of 30 and 19 in male and female value. Now, before going to causes of hepatic causes of raised ALT, we should consider some of the condition in which there are rises in ALT level, and among these the conditions in the bold are most important, like myocardial infarction, congestive heart failure, and even strenuous physical activity can give rise to high ALT and AST. And common conditions that we should think of are hyper and hypothyroidism, inflammatory bowel disease. These are the most important conditions. Now, going to characteristics of elevated concentration of the transaminase, there is no clear-cut demarcation between level which is known as mild rise or moderate or severe rise, but it is commonly understood that less than 2 times the upper level of normal limit is considered as borderline, mild means 2 to 3 times, moderate 4 to 20, and more than 20 is considered as the severe. So mild elevations are commonly found in NAFLD, now known as MASLD. Moderate elevations are found in chronic viral hepatitis, alcoholic hepatitis, and numerous chronic liver diseases. And marked elevations are seen in ischemic hepatitis and then toxic injury due to paracetamol. One point is that height of elevation of aminotransferase is not prognostic, and it does not show the disease characteristics. And another thing we need to consider is that if there is rapid falling, it may not correlate with the improvement in the necrosis, but sometimes it may show that the patient is deteriorating. Rapid fall is seen in soft liver if we correct the blood pressure adequately. Now, two broad division of causes of elevated aminotransferase as per Schlesinger. It can be chronic mild elevation or severe acute elevation. In between are the moderate, which encompasses most of the diseases. And again, this can be divided into ALT more than AST and AST more than ALT in two different conditions. Now going through etiology. So chronic mild elevation, also known as more than 5 times of normal or less than 150 IU of ALT is known as mild elevation. And hepatic causes include autoimmune hepatitis, chronic viral hepatitis B, C, D, hemochromatosis, medications and toxins, and Wilson's disease and NAFLD. Non-hepatic causes comprises celiac disease and hyperthyroidism. It can also be seen with AST more than ALT in alcohol-associated liver disease and liver cirrhosis. And in non-hepatic cases, hypothyroidism, myopathy, and strenuous exercise are the most common causes. So here, one algorithm. So if someone presents with mild liver enzyme elevation, then we should take history and take the history of medication and alcohol use. If there is, sorry. So if there is history suggestive of extrahepatic cause, then we can refer to respective department. If there is alcohol and then medicine use history, then we can stop alcohol or medicine and then repeat the test. If it comes to normal, then we don't need to follow. If there is persistence of the alterance, then we should think of presence of risk behavior like that sexual promiscuity, etc. And then family history also important. Then we can consider the measurement of the transferrin saturation, and then middle-aged women with risk group of autoimmune hepatitis. So if there is viral etiology, we can treat that. If no viral etiology, transferrin saturation is more than 45%, then we should go for HFE gene mutation test. If it is negative, then we can go for test for copper metabolism, alpha-1 antitrypsin deficiency. And if there is serum marker of autoimmune hepatitis, we can treat accordingly. And if nothing is found, then we go for imaging and we go to screen for NAFLD. Now, severe acute elevation can be seen in acute bile obstruction, acute SBOTO, also known as Budd-Chiari syndrome, acute viral hepatitis, autoimmune hepatitis, drugs and toxin, ischemic hepatitis, and Wilson's disease. With more AST than ALT, it can be seen in medication or toxin in patient underlying alcoholic liver disease. And acute rhabdomyolysis is the important cause of non-hepatic rise in AST more than ALT with severe acute elevation. So this is the pattern of severe acute elevation. So in case of ischemic hepatitis and toxin, we can have peak and then it come down easily. But in case of viral and drugs in presence of alcoholic liver disease, it will rise and then slow decline is there. So these are some of the common conditions how to differentiate. In ischemic injury, it is usually 10 to 50 times, and then rising bilirubin is less, and then there is also ALT to LDH ratio less than 1 and presence of comorbid condition. Similarly, in toxic injury, it is almost similar like ischemic, but patient gives history of taking those toxins. In acute viral hepatitis, it is 5 to 10 times of the upper level of normal limit, and bilirubin level is 5 to 10 milligram per deciliter, and there is presence of some comorbid presence of some symptoms like jaundice, pain, abdomen, vomiting. In acute biliary obstruction, there is 5 to 10 times rise with bilirubin also rises and alkaline phosphatase is raised. In alcoholic hepatitis, 5 to 10 times of the normal, and then bilirubin is also 5 to 10 milligram per deciliter, and AST to ALT ratio is more than 2. Now, to establish the diagnosis in acutely elevated aminotransferase, these are few of the conditions. So, if there is history of hypotensive episode, acute CHF, go to ischemic hepatitis diagnosis. If the patient are living in endemic zones, high sexual promiscuity, male sex to men, then we can think of hepatitis infection. If there is concurrent presence of pneumonia, diarrhea with rashes negative for hepatotropic virus, then we can go for systemic viral and bacterial infection. if there is acute alcohol abuse with binge drinking associated with raised MCV, raised WBC, raised bilirubin and prolonged INR, it is alcoholic hepatitis. And if there is history of recent intake or ingestion of medication or even change in medication, ATT, then we can diagnose DILI. Then what are the conditions of chronically elevated aminotransferase? So if the patient are coming from endemic zone and with high risk behavior, we should think of viral hepatitis. Presence of features of metabolic syndrome, and we rule out other possibility of autoimmune hepatitis, then it is NAFLD or MASLD or even can be NASH. If they are positive for autoimmune marker and liver histology is consistent with autoimmune hepatitis, then we clinch the diagnosis of autoimmune hepatitis. History of alcohol abuse, raised MCV, uric acid and triglyceride, AST to ALT ratio more than 3, we go with alcoholic hepatitis. And if there are history of drug intake, especially methotrexate, amiodarone, isoniazid, then it is going to be DILI. So these are the list of medicine we should consider, and we should ask for the history. Very commonly prescribed, and sometimes it is also available over the counter. And among these antibiotics like ciprofloxacin, ATT like isoniazid are very important. Anti-epileptics like carbamazepine, phenytoin is important, and statins we commonly use, so we should also take history. And then use of NSAID, acetaminophen, and anti-diabetic drug like glipizide, chlorpromamide and tolbutamides are very common. And we should also think of drugs and substance abuse like cocaine, heroin, methamphetamines. And another most important in our region is the herbal medicine and homeopathic medicine. And last topic will be evaluation of abnormal liver enzymes in otherwise healthy patient can pose a challenge to a experienced clinician. It may not be necessary to pursue extensive evaluation for abnormal liver test, as it can have financial value. And conversely, failure to investigate the mild or moderate liver enzymes elevation could mean missing the early diagnosis, and it can be seen in 1 to 9% of normal cases. So to conclude, elevated aminotransferase is one of the common problems faced by the physician. Proper history taking is important. History of drug or alternative medicine should be properly taken. Comorbid conditions should always be sought for. Algorithmic approach can lead to diagnosis of the disease most of the time. Thank you very much.
Thank you, Dr. Sudhanshu, for an excellent talk. Since this is a meeting for primary care physicians, suppose what will be your advice to a physician when a patient comes, asymptomatic patient comes with just a raised transaminase. So as you find the causes of, the raised enzymes are plenty, extrahepatic and hepatic. So you cannot do all sorts of battery of tests. So what will you advise to a primary care physician, a patient who comes, as asymptomatic patient comes with a raised transaminase? So what are the initial approach or the initial advice for the physician?
The most important thing is the history. History taking and physical examination is the most important. So we can clinch most of the diagnosis by history taking itself. So next thing is the elevation, whether this is mild, moderate or severe. We should think of whenever there is severe elevation, they need immediate hospitalization. That is very important. And next comes the moderate, in which the diagnosis is always challenging, and we need batteries of tests for that. So for mild elevation, what is very important is that they may be taking over-the-counter drugs and herbal medicine for many reasons. That is the most important cause in our case. So after negating that, and then about alcohol abuse and IV drug abuse, So after negating that, we can go for the further test. So it is not always important that we should always go for the batteries of tests, but we should wait and watch also. Sometimes only observation and elimination of the causes can clinch the diagnosis.
So, any questions from the audience? Hello? So we see a few patients in which there is no typical history of any cholestatic jaundice, but liver enzyme GGT, particularly isolated elevation of GGT, which is elevated more than 2 to 3 times upper limit of normal, and patient doesn't have any other complaints, and non-alcoholic, and ultrasound only mild fatty liver, but they are worried about the elevation of GGT. So how do we counsel those patients?
In most of the cases, what I see is that raised GGT along with aminotransferase in non-alcoholic patient is, there are two important causes. One is NAFLD itself, we can have raised GGT, and another one is different drugs, because sometimes they may not give you history of different drugs. So it is very important that you should ask what are the medicine they are taking. They may not be telling you what herbal preparation they are taking. Because this herbal preparation is very notorious in causing liver damage.
Sir, when AST and ALT is elevated along with GGT, okay, we suspect that ongoing viral damage, liver damage is going on. But my question is pertinent that AST ALT is normal, and I have seen around 7 to 8 patients till now. Because only GGT is elevated, there is non-alcoholic, no history of metabolic syndrome, they do not give any definite history of antibiotic use or any complementary alternate medications, but still the GGT is elevated. And that is how to counsel those patients. Liver enzyme is normal.
Mild elevation of GGT, it can be followed up and then you can repeat the test in 3 months.
Okay,
but
sir.
If there is persistent elevation and there is a mark, then you should undergo non-invasive test. You should undergo 3 Tesla MRI to rule out primary sclerosing cholangitis, because that is one of the reason that we miss in the ultrasound, and then other tests are negative. And if it is negative for PSC, then go for the liver biopsy.
Okay, sir. Thank you.
We can close the session now. We'll request you to start the new session, the new speaker. Thank you.
So for our next topic, approach to a patient with cholestatic jaundice, I would like to invite on stage our chairpersons, Dr. Manoj Kumar, Dr. Alok Mantri, Dr. Ansuman Singh, Dr. Saroj Kant Sahu, Dr. Akash Dobhada, and Dr. Bhagyasri Panda. Please come onto the stage and start the session.
Now going to start our next session, approach to a patient with cholestatic jaundice. I'd like to introduce our speaker, Dr. Susan Sethi. He needs no introduction. He is a senior consultant gastroenterologist, Department of Gastroenterology, Apollo Hospital, Bhubaneswar.
Dignitaries on and of the dais, a very good morning and welcome to all of you.
At the outset, I am thankful to Team INASL organizing committee to giving me an opportunity to talk on approach to the patient with a cholestatic jaundice. So jaundice, as you know, is the yellow discoloration of sclera and urine, and cholestasis is an impairment of bile formation and or bile flow, which may clinically present with fatigue, pruritus, and in its most overt form, jaundice. Cholestasis may be classified as intrahepatic or extrahepatic. Intrahepatic cholestasis may result from hepatocellular functional defects or from obstructive lesions of the intrahepatic biliary tract distal from the bile canaliculi. Cholestasis is considered chronic if it lasts beyond 6 months, and asymptomatic patients are generally identified when routine laboratory tests are being performed and during workup for another disease when an increase is noted in serum either ALPOS or GGTB level. When do you suspect cholestatic jaundice? Cholestatic jaundice you can suspect if patient is having jaundice, of course, which can be progressive or intermittent, pruritus, pale stools and dark urine, pain abdomen, picture suggestive of fat soluble vitamin deficiency, which is present to the tune of 10% of cases, steatorrhea, fever with chills with point fevers towards cholangitis, and prior abdominal surgery. Somebody had underwent cholecystectomy or some other surgery, said you are suspecting, you can suspect. Signs are icterus, fat soluble vitamin deficiency, which includes scratch mark over the body, and this because of bile cell deposition on the epidermis, and palpable mass in abdominal or palpable gallbladder. Laboratory evaluation includes elevation of bilirubin, which is predominantly direct, ALPOS elevation more than 1.5 upper limit of normal, and gamma GGTB more than 3 times of upper limit of normal. 2 up to 3 times normally can be seen, as we were discussing last time, normally also can be seen. Isolate ALPOS may point finger towards bone disease, pregnancy, and may be seen in PA, progressive familial intrahepatic cholestasis. But when it combined with GGTB, then liver disease is more suspected. So extrahepatic versus intrahepatic jaundice, how you get the clue? Some clinical clues may point finger towards the possible causes. It is important to distinguish extrahepatic to intrahepatic causes, not only for diagnostic purpose, but also therapeutic purpose. Symptoms or signs in favor of extrahepatic jaundice includes pain abdomen, palpable mass for abdomen, history of biliary surgery. Sometimes you get pain abdomen because of dilating pain, because of stretching of the glycerin capsule in case of intrahepatic also in viral hepatitis, but predominantly it is present in extrahepatic causes. History of biliary surgery, fever with chills, which are the suggestive acute cholangitis and clay colored stools or melena. Melena indicates hemophilia, or in case of periampullary malignancy also you can get melena. Intrahepatic jaundice, pruritus is more predominant, and it is more during evening, predominantly involving palms and soles and fatigue. Fat soluble vitamin deficiencies are present. Occupational and drug history, including complementary ayurvedic medications or over-the-counter medications, should be taken, as my previous speaker was telling. Alcohol history you might have missed, you have to take it. Family history, which include familial cholestatic jaundice and other chronic illness like IBD, but for primary sclerosing cholangitis and diabetes mellitus, whether fatty NAS is very common, autoimmune diseases, and the suggestive autoimmune, feature-suggestive autoimmune diseases or giantism are there. In special populations like pregnancy, pregnancy-related cholestasis occurs in 3rd trimester of pregnancy, and usually it is, it gets cured by termination or delivery. So, and along with that, HIV infection, hospital patients like sepsis and TPN. In case of sepsis, many of the patients with sepsis, we can catch cholestasis, and in ICU, when we are seeing our patients, so we have to go detail. So what are the causes? Whether it is induced by antibiotics or sepsis proper, you have to take care of that. And also TPN also causes cholestasis. So these are the causes of extrahepatic cholestasis, which includes AIDS, cholangiopathy, ampullary cancer, ascariasis, and extrinsic. These are the intrinsic causes, and extrinsic causes includes gallbladder cancer, malignancies, choledochondritis, Meniere's syndrome, pancreatic cancer, pancreatic cirrhosis, and pancreatitis, especially head of pancreas, can obstruct the common bile duct. So then the drugs, some drugs they cause cholestasis. That either can cause bronch cholestasis, for example, anabolic steroids, cholestatic hepatitis, for example, angiotensin converting enzyme inhibitors, and or NSAIDs. Granulomatous hepatitis can be caused by azathioprine and allopurinol. Vanishing bile duct syndrome can be caused by amoxicillin clavulanic acid combinations, which is commonly used, and PBC, PSC, they are also important causes. Granulomatous liver disease includes brucellosis, tuberculosis, etc., etc. Idiopathic granulomatous hepatitis can be seen in sarcoidosis. Other causes like Crohn's, heavy metal exposure, Hodgkin's disease, they also can contribute cholestasis. Idiopathic adult ductopenia apart from viral hepatitis, which these viruses, idiopathic ductopenia, adult ductopenia can be seen in progressive familial intrahepatic cholestasis or PP type 1, type 2, type 3, BRIC or benign recurrent intrahepatic cholestasis type 1 and type 2, malignancy, hepatocellular carcinoma, cystic fibrosis, metastatic disease, paranephrotic syndromes, infertility disorders, etc., etc. And of course, sepsis as we discussed, and intrahepatic cholestasis of pregnancy. So, to approach a case in case of cholestatic jaundice, you have to see whether bilirubin usually it is total, it's predominantly direct or indirect. If it is indirect, then it could be something else because of hemolysis or some other causes. But if it is direct, then you can think of cholestasis. Along with that, elevation of enzymes are more important. Alpos in various forms. Alpos is secreted not only from liver, hepatocytes, bile canaliculars, also from bone, placenta, and intestine. So, along with GGTP, which is liver-specific enzymes, helps in identify liver causes of raised alphos. Other methods to perform fractionation ALP are also elevated. Hepatocellular enzymes AST/ALT may be normal or mildly elevated due to hepatocellular injuries, cholangitis, or inflammations. In few instances, even in case of extrahepatic cholestasis or common bile duct stones, you can get liver enzymes or AST/ALT elevation to the tune of 800 to 1000 also. Albumin may be decreased in case of chronic cholestasis and in acute inflammations, and globulin may be elevated in case of autoimmune disease. Other broad investigation includes viral serological markers, as we discussed. Hepatitis A and E can cause cholestasis. Hepatitis C can also cause cholestasis. ANA, ASMA, AMA until CAMP1, and other causes of cholestatic jaundice should be ruled out. Regarding radiological interventions or imaging, if we talk of imaging, transabdominal ES is reasonably fast step. It is because it is easily available, low cost, and good sensitivity. Sensitivity to the tune of 55 to 91%, and specificity varies from 82 to 95%. But the problem is it is operator dependent and might not visualize distal CBD and pancreas. As you know, the bowel gas, they obscure visuality, the pancreas cannot be visualized. And of course, common bile duct stones may not be picked up by ultrasound. If bile duct is not dilated, only in case of 50% cases it can be picked up, and if it is dilated, up to 75% cases it can be picked up. It can differentiate between intrahepatic and versus extrahepatic, whether ductopenia or surgical jaundice, and dilated bile ducts in US or clinical history might provide a strong clue to extrahepatic cause. CT scan is of high sensitivity and which is to the tune of 96% and specificity to the tune of 100%. High resolution compared to ultrasound, it is not operator dependent, but the problem is that it is radiation exposure is involved, contrast reactions, nephropathy are involved, but it can identify tumors as small as 5 mm or less. Coming to MRI is from diagnostic standpoint, whatever the methods modality we are having, MRCP offers highest sensitivity and specificity reaching among almost 100%, and some small duct disease may be missed. Superior imaging of bile ducts compared to both US and CT. The problem is that time taking and requires patient cooperations. Cost is another factor. Some people they may not undergo MRI because of claustrophobia, and pacemakers are an issue nowadays. Of course, the majorities are MRI compatible. So these are the MRCP pictures. You can see stone can be picked off, and coming to ERCP, it is gold standard for imaging biliary tree, and it carries the highest sensitivity to the tune of 98% and specificity to the 100% compared to any other imaging modality. Direct visualization of bile ducts at the periampullary region can acquire tissue of diagnosis, blood cytology and ampullary biopsy. Simultaneous therapeutic intervention can be done. This is the major advantage of ERCP. We can do simultaneous therapeutic intervention. The problem is that it requires sedation, difficulty in altered anatomy, post-ERCP complications are there. But for you, please remember that ERCP only used for diagnostic purpose and it is not indicated routinely. When we are combining diagnostic and therapeutic, then ERCP is the best choice, of course. So these are the ERCP pictures. Some of the ERCP pictures: cholangiocarcinoma with malignant biliary strictures, distal biliary stricture to chronic pancreatitis. Choledocholithiasis, sclerosing cholangitis, and ascariasis. Percutaneous transhepatic cholangiography, accuracy similar to ERCP, it reaches 100%. For lesions proximal to hilum and inaccessible ampulla, has higher rate of complications, non-dilated bile ducts with difficult access. Simultaneous therapy can be planned, but it's rarely used like ERCP for diagnostic purpose. Endoscopic ultrasound is a very good tool and handy nowadays, and alternative uses a similar diagnostic accuracy of MRCP. One patient came to me who was diagnosed outside in MRI and CT both a small cholangiocarcinoma. When patient came and oblique periampullary tumor, when I started to give some palliative therapy or to take a broad cytology, I did not notice any periampullary lesion, and I put the US and I saw a small stone, and when I combined with the ERCP on the same table, then stone came out, and then patient relieved. Drastically, the prognosis changes from a malignant disease to a benign thing. So endoscopic ultrasound is very good in that. And the other advantage of tissue sampling or biopsy whenever needed can be therapeutic in some cases too, as I told. But the problem is that it requires anesthesia, sedation, and requires experienced operator to a stiff learning curve. Nuclear imaging studies, though helpful like hydroscan, though helpful in diagnostic cholestasis, cholecystitis is not routinely used, but helpful in early cholecystitis to prevent biliary leak. And early cholecystitis cannot be picked up by any other modality, but hydroscan can pick it off. Then liver biopsy provides precise information regarding pattern of inflammation and fibrosis, can differentiate the majority of etiology when used with clinical imaging and finding. Indicated in chronic intrahepatic cholestasis or prolonged jaundice, but the complications in 1% mortality to the tune of 0.01% can be completely normal in acute obstructions also. So three major categories we see: disorders involving bile duct, disorders not involving bile ducts, and hepatocellular cholestasis with only minimal histological abnormality. These are the two things we look for in liver biopsy. For an example, this is primary biliary cholangitis, and this is primary sclerosing cholangitis. The typical onion skin appearance can be seen in case of liver biopsy. So these are the typical biliary lesions, and we discussed now. So diagnostic approach should be like this: history, physical examination, routine laboratory investigations. If alphos is elevated, then we can think of biliary tract obstruction, which is a consideration. We do ultrasound first, and ultrasound the clinical likelihood of biliary obstruction, so you can go ahead with therapy, whether it is ERCP required or not. And if it is intermediate, it's not very informative, then we can consider MRCP or US. We got dilated duct. Again, we go for ERCP or therapy. Then if alphas are not elevated, it is normal. If evaluate hemolysis, so the hemolysis is there in only predominantly in that hypobilirubinemia is there. If biliary tract obstruction is not a possibility, then biochemical studies for specific causes of liver disease like autoimmune or other things should be ruled out. If they are positive, then go to specific therapy. If negative, then consider liver biopsy. Similarly, if clinical likelihood of biliary obstruction is intermediate, and if MRCP US are normal, then you can go for liver biopsy. So the drugs to be reviewed, drugs not dilated intrahepatic cholestasis, you can go for these parameters. Drugs dilated, we can get for CT and ERCP, CT and ERCP. So utilization of imaging study, extrahepatic cholestasis can be due to stone, tumor or cyst or stricture. Dilated bile ducts are US. Further workup based on suspected diagnosis. Emphasis on imaging biliary tree. Available modality as you discussed: CT, MRI, US, and percutaneous ERCP and transhepatic cholangiography. Utilization of imaging studies as you discussed: first US, then you proceed. If biliary tree dilatation is not seen, intrahepatic causes should be worked off. If dilated bile ducts are seen, ERCP PTC can be planned. However, if clinical suspicion is high for biliary obstruction, MRCP or US may be indicated in patients with negative finding. Intrahepatic cholestasis, similarly, bile ducts not dilated US could still be obstructive or periampullary act on clinical suspicion. Intrahepatic cholestasis is usually chronic, acute in case of viral, alcohol or drug. Diagnosis in appropriate clinical suspicion based on history, like drug-induced liver injury. Sometimes you might have missed history of CAM, as we discussed. Causality assessment, pregnancy, malignancy, sepsis, infection should be taken care of. MRCP or US to look for bile duct abnormality, and serological studies should be done, and diagnosis unclear, then you go for liver biopsy. This is the same thing. Proceed to treatment. Management is planned as per diagnosis and extrahepatic causes, specific therapy. In intrahepatic causes, withdrawal of offending drug, UDCA, specific therapy like IgG for disease. Predominantly long-standing intrahepatic causes like pruritus, fatigue, fat-soluble vitamins, osteoporosis, they need treatment. pruritus can be treated by cholestyramine or by rifampicin or ursodeoxycholic acid, and sometimes naltrexone and saline therapy pruritus. Sertraline, you have to take care of this the psychosocial elements, and the liver transplantation. Finally, liver transplantation. So, and for fatty chronic cholestasis, no definitive treatment is found. Only you have to reassure. Osteoporosis, maybe Dexascan should be done, and vitamin D, vitamin A, E, K should be supplemented. Other works of management as per portal hypertension or alpha beta proteins as per protocol. So, ladies and gentlemen, to conclude my talk, I will be saying cholestasis is an impairment of bile formation and or bile flow. It can be intrahepatic or extrahepatic. Common intrahepatic causes include strokes, viral infections, and autoimmune disorders. Extrahepatic causes include stone, stricture, tumor, etc. Clues you can get from history and physical examination, and it should lead to suitable investigations and further planning and management. Management of intrahepatic cholestasis are causes specific and symptomatic, and extrahepatic causes obstructions warrant intervention in the form of either endoscopy, radiology, and or surgery, which might include liver transplantation. Thank you for your presence.
Excellent talk, sir. Excellent talk, sir. I have one question regarding intrahepatic cholestasis. Intrahepatic cholestasis, the cause is granulomatous hepatitis, sarcoidosis, or tuberculosis. How frequently you encounter those patients?
Yes, tuberculosis, in tuberculosis especially, either it can be because of the disease per se, or it can be because of drugs as well. So that we see frequently. Sarcoidosis also, sarcoidosis is not very common, and we can also see in sarcoidosis, but tuberculosis, as you told, we can see as a part of granulomatous hepatitis, initial presentation, or once we give treatment, we also can cause cholestasis.
Yeah, I have seen one patient, she's 30-year-old female, when I was doing my DM in Calcutta at that time. So his only complaint was presented with fatigue, generalized weakness, then presented with history of progressive jaundice for 2 months. There is no history of any complementary alternate medication, and or any alcohol or drug abuse, nothing is there. So on suspicion, we did the test, and we did the liver biopsy. We got granulomatous hepatitis for the patient. We gave ATT for 6 months, and it's a miraculous recovery of the patient. And there was no other involvement, of lymph node involvement or pulmonary involvement, nothing was there. Only per se granulomatous hepatitis in the liver, it was there.
Right, in this protocol, if you are not getting anything, but still the liver enzymes are elevated, especially alpha positive are elevated, you are not getting anything, then obviously you have to do liver biopsy to establish the diagnosis. And many times that is the only thing to establish diagnosis in case of tuberculosis.
Okay, thank you.
Yeah.
So, thank you, sir, for this excellent presentation. And I just want to clarify some doubts, sir. Okay, we have a patient who she is a 18 years old girl. She didn't have any ANA positive, but all the diagnosis we have done was negative. So we are thinking maybe it may be autoimmune hepatitis. I want to know that in how many cases autoimmune hepatitis may be an initial presentation of autoimmune disease before systemic manifestation or the systemic manifestation.
Yeah, systemic manifestation you may not get initially. Autoimmune hepatitis, even if autoimmune, 30% of cases of autoimmune hepatitis directly they present with CLD also, chronic liver disease also. And ANA is not 100% positive in case of autoimmune hepatitis, and other markers are also available like ASM and LKM1. But we have specific diagnostic criteria for diagnosing autoimmune hepatitis, and many times there is a debate whether we should go for liver biopsy or not. But many times we have to do liver biopsy to establish autoimmune hepatitis. We have to follow specific criteria.
Initial presentation.
Yes. Enzyme elevation also. Only fatigue, enzyme elevations can be.
Sir, patient has already developed cirrhosis. You are suspecting autoimmune hepatitis. So, do you think it will be useful to do liver biopsy in that setup?
Yeah, still, if cirrhosis is already established, that in that case, it is early, then whether you are debating whether you have to give treatment for autoimmune hepatitis or not. In that case, you can have transjugular liver biopsy to establish if it is needed, then you can have transjugular liver biopsy in case of early cirrhosis. But of course,
if it is compensated, you can establish the diagnosis.
Decompensated cirrhosis, otherwise also you may not help.
Decompensation, after decompensation, there is, I don't think it has any role of giving.
Steroids you cannot give, and or it may not help.
So, you say we are having compensated cirrhosis, you want to rule out AIH, you do biopsy. After that, you can start the treatment for AIH when patient is having complement cirrhosis at that time.
Yeah.
Okay.
Yeah.
In question.
Sir, thank you for talk, sir. Sir, I want to ask about the role of EUS in altered anatomy, sir. Any help regarding the cholestatic jaundice, sir?
Altered anatomy.
Yeah.
Altered anatomy, basically, EUS when it is needed in altered anatomy also in surgery it can be done, because in case of cholestatic jaundice, if it's because of some other some obstruction which is not very obvious, then you can give therapy. Otherwise, EUS per se, as an evaluations, you may not get much information if you are having other modalities. But if you are planning some interventions, yes, it will be somebody as I discussed, somebody is having small stone which is missed, or small ampullary tumor, you can get some biopsy. Small cholangiocarcinoma, you can get some biopsy. Of course, that may be of help.
Thank you, sir.
I think excellent talk.
Thank you.
I'll ask two questions as a course moderator. From physician's perspective, the role of UDCA and the role of cholestyramine. What would you advise UDCA in which condition in cholestatic jaundice, or it should not be given? Number one. And cholestyramine, what dose should be given? Since it's not a very palatable drug, how we should explain to the patient?
Regarding UDCA is the first line therapy. Usually we give, any patient comes with cholestasis, we give UDCA. That is the first line therapy. If patient is not responding to UDCA, then I add actually cholestyramine. Cholestyramine 2 gram, every 2 gram sachet, and patient may take 2 to 3 times. And if it is not palatable, that's the reason we advise the patient to take with lemonades, lemon drinks and all. It's a effective drug, what I see. Especially in case of pregnancy related cholestasis, every day, maybe in a week, 3-4 cases I see pregnancy related cholestasis, and cholestyramine usually helps in that.
Any alternative therapy other than cholestyramine?
UDCA, cholestyramine, rifampicin, and naltrexone. So these are the therapies basically.
How long somebody should take rifaximin or
rifampicin is a double-edged sword. I mean, I don't use frequently if they are not responding. Otherwise, also we can give, because it can cause precipitated jaundice also. So PN Rasa can throw some light.
See, another very not an uncommon condition is a BRIC, benign recurrent intrahepatic cholestasis, where the other liver functions, clinically he is well, but he comes with a recurrent attacks of episodes of a pruritus, and they will have any very intense pruritus. There's the cases where rifampicin is added, and it gives a that is after you fail to and the liver enzymes, even if they are mildly elevated, you don't have to worry about the rifampicin in these patients, right? And the ursodeoxycholic acid is concerned, and another condition where there is severe cholestasis is acute hepatitis A. You must have seen, the enzymes keep rising, the enzymes keeps coming down, bilirubin keeps increasing, and the patient has got a severe cholestasis. And they are not, they don't respond to the ursodeoxycholic. There, of course, you cannot give rifampicin. Please remember, rifampicin is given only in BRIC patient. And cholestyramine is given in this one. Usually they do tolerate, only thing is sometimes they will have a nausea. Already they are having nausea because of hepatitis. So you can give them after anti-nauseating drugs, any one of them, and then
because pruritus is so troublesome, once they get relief from that, other symptoms usually they do tolerate well.
Some of us use cetirizine, but it's not effective, I know. But explaining patients with severe cholestatic pruritus is a very difficult problem.
Lotion and cetirizine you can give, but that is no evidence. Okay.
Which I found to be useful, but we don't have a good randomized data in these. But very practically is a steroid.
Yeah.
As long as you don't have any other contraindication, keeping in mind the diabetes and then other status, steroids do help in these people, and then pruritus improves. But having said that, you have to use it only in a selected population where you can follow them up. This one.
It is the question of liver biopsy in autoimmune hepatitis. It has to be done because the lifelong treatment and definitive treatment. If you, as brought out by Professor Sushant, you can't do a percutaneous, do a transfusion.
So we will conclude the session.
Thank you, sir.
We'll go for the next session.
Thank you.
So, moving on to our next topic, approach to a patient with incidentally detected fatty liver on ultrasound. For the session, I would like to invite on stage our chairpersons, Dr. Lalatendu Mohanty, Dr. Sakti Patnaik, Dr. Bipad Bhanjan Malik, Dr. Rakesh Barik, and Dr. Chandan Das. Please come onto the stage and start the session.
Respected P.N. Rao sir, see, he needs no introduction. He is one of the stalwart of hepatology. He is the head of Department of Hepatology, AIJ, Hyderabad. So, sir, let's start the topic.
Thank you. Thank you. Thank you for having me here. Can I have the access from here only? Well, this is not a photograph. This is a hand-woven carpet which has been given by one of the person, Afghan residents, doctors who has come to our hospital and then is donated. And look at, see, the beauty of this. One of the common things which the patient comes to you, rather is not a patient. He is a person, he is a boy or somebody comes to you, is that, he's been detected to have fatty liver when he went for a routine physical examination. That is the commonest presentation. Or as we discussed, Sudhanshu has said in the first case, that he comes with an enzyme elevated. And these two are related actually. These two are very closely related, because if you have a fatty liver, you have to do AAT. If you have AAT liver, first thing is to do a fatty liver, right? Now look at this girl. She is only 18 years girl, and she has come to a gynecologist with a PCOD symptoms and ultrasound done for gynecological intent, but then it has been found to be grade 2 fatty liver. You do the fatty liver, estimations according to the grade 1 and then grade 2, grade 3. Simply, if the vessels are seen very clearly, it is only a grade 1. If the vessels are not seen clearly, it is a grade 2. If a diaphragm is also not seen, it is a grade 3. As you said, it is all the person who is behind is also sometimes, it may be that, grade 1 to, that's the reason people write grade 1 to 2 or grade 2 to 3, right? It's not a perfect estimation, right? Well, then on the left hand side, you see how to diagnose an NAFLD is mainly to rule out other causes of this fatty livers, right? And especially alcoholic liver disease. And on the right hand side, you see the panel. What is important is in the development of this fibrosis, F2, F3, F4, beyond F2 is at-risk patients. That means anybody who has got a above F2 is to go for a chronic liver disease and other complications. And therefore, people are looking at how to diagnose F2. Well, then why NAFLD is invincible and then invisible is because of these associations, which we know that the metabolic associations like global associations, and they keep on increasing, they are going to increase. On the left hand side corner, you can see that even NAFLD, lean NAFLD has also been projected in the world map here, and the burden is going to increase. And then I will say that for the health industry, there are only two things which are going to rule the entire health industry in the world. One is obesity and another is alcohol, and both are going to increase, and therefore there is enough of work for the health industries, doctors and the patients also. There is enough of work for them to be done. But then what next? Immediately after getting a fatty liver, what you do is a routine liver functions. Obviously, you have to do liver functions. And the one circle that I mentioned here, 2.5, 0.5, always please remember that one of the commonest causes of unconjugated bilirubin is a Gilbert's disease. Patients, unnecessarily, they go for all the investigations, ursodeoxycholic acid, all kinds of a thing. If the enzymes are normal, right, if you exclude a hemolysis, is equal to Gilbert's disease, right? Especially they come with the chits, previously only bilirubin having been done. And the lower bottom, I said that platelet count, right? Remember, one of the commonest causes of a lower platelet count, provided you've seen the MPV, you know the mean platelet volume is also there. Giant platelets are there. Please remember MPV, if it is high, then it is pseudo thrombocytopenia. So, any true thrombocytopenia, one of the important causes is to rule out a portal hypertension. Many of our liver patients, they go through hematology, get a bone marrow done, and then ultrasound, and then come to us for help. So, one of the things, right? And ALT, AST, always remember what is the normal for the lab here, which I mentioned here, that will tell you about the number of times. Normal ALT does not rule out fatty liver disease and then NASH in general, overall. But on the other hand, persistently normal ALT and then AST, you can be reasonably assured that he is not having an inflammation. Many obese people, you know, they are hugely obese, but their enzymes are normal. Throughout the year, throughout the life, they are normal. Some genetics and then microbiota play what is the protective things. Yesterday I told about some of the protective genes, you know, which these people may be having it. Well, then some of it. Then the next question is to see the basic things, you know, after that ALT, AST, and next thing to see, just weigh them, how much they are, and just take a measure, and then abdominal circumference. These are two things which have to be done. BMI, I need not tell you what is the difference between the West and the East, because when you go to the calculators, it will, all the calculators are from the West, and therefore it will show that beyond 25, it will show you as overweight. It is not overweight. As far as Indians are concerned, Asians are concerned, more than 25 is obese. Please, whenever patient comes to this one, please weigh, you know, and then put it on a round corner, what is his weight. If the patient has come to cirrhosis and then later, please ask for what is the weight before. Because by the time he comes to you, he may not be obese, he must have lost sarcopenia, has lost his weight. What is the recall weight? That's what I call. And recall weight, what is the highest weight when you achieved before, you must ask. And that is the weight, you know, which has led on to the condition now, the cirrhosis of liver. Second thing is abdominal circumference. This girl has gotten 87 centimeters. More than 90 centimeters for Asian male, more than 80 centimeters for Asian female or Indian is abnormal. And the waist circumference has been closely correlated with the CTs and other things which are visceral obesity. Visceral means abdominal obesity, and visceral means around the inside, around the omentum and then other fats is closely related, which is responsible for sending the signals to the liver for the further development of a NASH and then inflammation. But then afterwards what you have to do is an LFT, you do a lipid profile. And this is called a metabolic syndrome. The International Diabetic Federation 2007 is the one which we normally follow. You can see that the first thing is abdominal circumference is the first thing. If it is high, and any of the four below, what are the four simple things? Triglycerides, HDL, one is the blood pressure and one is an glucose. In this girl, you can see that 87 centimeters, she has got abdominal obesity, and triglyceride levels were high, 280 at this 18 years of age. HDL levels are markedly lowering, 38, and the other two of course have not yet developed, but I am sure she is going to develop after 5 years, either 10 years, she is surely going to develop either a diabetes or hypertension or both, right? So then some of the words like a MAFLD has been coined, that is instead of NAFLD, why call it a metabolic dysfunction associated for a liver disease. This has been there earlier also, but then MASLD and then MAFLD are the two ones. S means steatotic, F means fatty, that's all the difference. Although he said that what is in a name, but everything is a name. Don't argue with the pendant, because it is waste of your time. And then what is in the name is a different thing, but many people the world is divided between NAFLD and then MAFLD, and that's of course for you to be interesting. Next thing is to see whether there is a cardiovascular risk factors. People don't die of a liver disease. Fatty liver people will have a mortality because of the cardiac problems, and therefore every patient with a fatty liver must be looked for The lipid profile I already looked for. You must look for a cardiac and the diabetes, because diabetes and NAFLD has got a bilateral relationship. It is a progressive disease. People have taken a biopsy who did have an inflammation, who did not have an inflammation. As you can see, for the follow-up of 80 years, so and so people have developed, and the same people were followed for further many years, 20 years. Many more people have developed NASH. I mean, the liver-related mortality has occurred, and therefore it is a very progressive disease today's month. And next thing is to see, after having said that inflammation is there, this girl has got a metabolic syndrome, obesity, and then she's got a bright liver, she's got an ALT and an AST indicating inflammation. Next thing is to see whether fibrosis has set in or not, because I told you F2 and then above fibrosis are very important here. And you can see here that the fibrosis is closely correlated with the mortality, not only for the liver mortality on the left side, and then you can see all-cause mortality is also increased, indicating thereby that they don't die of a liver, but they may die of a non-liver causes also. One of the important is a cardiometabolic. The risk is there in them, both the cardiac and this one. Most of the cardiac associations and the diabetic associations, now they say that diabetic association, they say that if you are a diabetic, first thing is to do an ultrasound. They are following the same algorithm as we have. In fact, they are much ahead of us. And then, largely asymptomatic. That's the problem with us. Next thing is to see, we have a liver biopsy. Of course, neither the doctor nor the patient would agree, and doctor also will not have a heart to do a liver biopsy for a patient, healthy patient who comes to you with this, and only it's to be done only when the conflicting interests are there. Next thing, biopsy, of course, why it is not done is 150,000. Sampling errors will be there. If you look at it, this one, it will be normal. If you look at it, the fibrous septa, and if you look at the nodule, and therefore sampling errors are there, apart from the risks which are associated with this one. Next thing is what to do is that with the information which you already having it, decide biomarkers. The biomarkers should decide whether there is a fibrosis has set in or not, right? Non-invasive markers. Right hand side, you can see simple things, ALT, AST, that one between routinely done. Just taking the AST and the platelet ratio, that is what we call an APRI, you can exclude or include significant amount of a fibrosis. Don't bother about the yellow ones which are there, but concentrate on APRI only. You see here in APRI, AST and then platelets are all what is required. And you can just put in the data and then you can get the answer immediately. And then you see how the platelets count is indicated here. And as far as INASL data is concerned, any APRI of less than 0.045 rules out a significant fibrosis. So in the OP itself, you can decide whether the patient has got a fibrosis or not, right? Next thing is FIB4. This is very, very, very important. What you require is, apart from AST and then platelet count, here ALT is required, and then age is the one which is you have to add, which are there already. So take out your mobiles, go for FIB4, add the data there, and then you can see very easily what is the FIB score here, less than 1.3, and then 1.3 to 2.67, more than 2.6. More than 3.67 indicates a significant fibrosis. Less than 1.3 rules out a fibrosis. Always there is a via media is there. Indian data, the INASL criteria, FIB4 less than 1 rules out a significant fibrosis with a high sensitivity. APRI I told you, FIB4 I told you. Another is NAFLD fibrosis score. Here again it is there, but the NAFLD fibrosis score is specific for fatty liver disease. Whereas APRI and then FIB4 are for all the other liver diseases. For a moment, you can even forget APRI, but remember only FIB4 is the one which is commonly used across the world. NAFLD, again, the NAFLD fibrosis score is there, and there again you require only very, very simple routine parameters. There are apps are there which you can do this. Next thing is the class 1 biomarkers are the one very, very complicated. We don't have to go there. Nobody will do procollagen. Who will do all those things? Nobody will do that one. So on this one, complicated. It's not a very complex, but this is APRI. The very simple things are required. You can know that you have a availability as here. And these are the ones when both of them, when they club, you have some other indices are there. Fibrospect, fibrometer. Fibrometer is commercially, it's also available. They add other things and then they come to a conclusion. We will not go into the details here.
So how to identify the NAFLD patients at a risk of a NASH or a fibrosis? As I told you, you require an NAFLD score, you got a FIB4 here, and FibroScan, which is easily available. And look on the right side, you have to look for a diabetes and then other metabolic parameters. This is a diagram which tells you on the left side the NAFLD fibrosis score, on the right side you got a FIB4 score. You see here that what you require is only age, AST, ALT, platelet count, BMI, albumin, impaired glucose or diabetes. Well, these are the ones which are there daily. Every patient we have this data is there, and therefore for a moment you can even I say that NAFLD fibrosis score also you forget because it's not very commonly used across the world. FIB4 is the one which is used there. It requires only these parameters: age, AST, ALT, platelet count is all required. Only thing, remember, platelet count, please look at the MPV and then divide. Otherwise, all of your patients will have a low platelet count. Now, they are writing MPV. Previously, they were not writing. They are only writing the giant platelets. There is intermediate task there in the center. What to do with those patients, we will see later, a little bit later. It is the F2 stage which is very difficult actually. That's the reason why all these algorithms are coming there. Next thing is, of course, we got an imaging, we got a FibroScan, we got an RP, we got an MRI. And the cutoff levels are here down, and you can see here that this girl comes to the bridging fibrosis here because her this one is high, and then these are the, you can get any ISL criteria, Indian Association for Study Liver criteria, significant fibrosis as far as the liver stiffness management is concerned. This girl, we did an MRI for only theoretical purposes. She didn't agree for a liver biopsy. Mean hepatic parenchymal stiffness is 4.7, which is an advanced fibrosis at the age of 18 years. And fat was 41% of the liver was occupied by the fat. And you can imagine. And therefore, this girl has been found to have a fatty liver incidentally. Ultrasonogram has shown a bright liver. And then elevated AST, ALT in the LFT indicating that she has an inflammation. Next thing is she has an insulin resistance. What you require insulin resistance is fasting sugar anyhow is there. Nowadays fasting insulin is also done. Fasting insulin into fasting glucose divided by 405 will give insulin resistance. And more than 2.5 insulin resistance means that means the patient is having an insulin resistance. This girl had more than 2.5, insulin resistance was already there. She had a metabolic syndrome is there, MR elastography and RP, other things are clearly there telling that she has got an advanced fibrosis at the age of 18. And therefore, what is the algorithm there? First thing is to see that whether FIB4, as I told you, that on the left hand side less than 1.3, I just take 1 minute more. On the right hand side, you've got a FIB4 of more than 2.67. Via media, what to do is an intermediate risk. And the intermediate risk, you can do an LSM. If LSM is less than 8, again you can be okay. More than 12, I think significant fibrosis is there. Again, you will have in the middle, you will have something called where intermediate. So, if the FIB4 is less than 1.3 and then LSM is less than 8 kPa, is a very low risk. On the other hand, if FIB4 is more than 2.67 and LSM is more than 12, and then there is a high risk, then it has to be sent to a specialist. And if it is a via media, sometimes you have to still follow them up, and then either a liver biopsy if they agree for, if there is a comorbid conditions are there, right? And then now we are living on the left hand side with the algorithms. What is required future is artificial intelligence, right? We have got a big amount of data is there, and next we don't have this elephant for NAFLD, but we want a large collection of data, and then big data analysis is one. So ladies and gentlemen, NAFLD and then ALD are lifestyle diseases. As predicted, there is going to be a phenomenal increase in the future, and therefore everybody will having their handful of work, both the health industry, doctors, everybody will be having. Ultrasonogram and our elevated liver enzymes are the first ones that attract our attention of the patient and also the doctor. Most important is to rule out a significant, rule in or rule out a significant fibrosis, for which I have told you FIB4 can be used, and the FibroScan can be used in about nearly 80% of the patients. You can say by simple means whether there is a fibrosis is there or not. Well, the liver biopsy has its own limitations. One can apply non-invasive simple biochemical markers to rule out or rule in a significant fibrosis. For intermediate scores, you can add a FibroScan to further improve diagnostic accuracy. liver biopsy only in rare situations of association with the comorbid conditions, where you cannot rule out an autoimmune hepatitis, where you cannot rule out a significant alcoholic liver disease. Thank you very much. Sorry, I have taken about few minutes more, and then I thought it.
Thank you very much, sir. Thank you, Dr. Bhendra, for the wonderful, crisp, and very, very precise and informative talk. This is a very common clinical scenario where a patient come to you with a report and the patient is a diabetic and you give your lip service, like go for lifestyle modification and all. Really hardly do anything. But you see, RSSDI and all other forums, they are talking about a routine ultrasound in every diabetic patient, newly diagnosed diabetic patients. And of course, the HOMA IR, what you said, that has to be done in somebody is Indian obese patients. The session is now open for discussion. If
I will take a couple of questions.
Yeah.
As Dr. Rao has told, all of you have heard, it's a very, very common situation. All of you have come across. I wish that more people should have been there listening this presentation, beautiful presentation. The incidental finding of a NAFLD or fatty liver in ultrasound is not new. All of us have come across, and for last almost 3 decades, I'll tell here, Professor S.P. Singh at CV Medical College, who was passionate to do a liver biopsy of these patients. The paper dates back 20 years. The first presentation from SCV with a biopsy finding of the patients presenting with fatty liver in the ultrasound. And then really a physician is worried how to approach them, whether to go for a intervention. Many people write UDCA and leave them. Many people tell lifestyle modification without any much reinforcement, but after the fibroscan, FAB-POSCO, the elastogram, things have come, it's time to assess, because this is a marker of insulin resistance and metabolic disorder. But Dr. Rao has already pointed out, we should not take it as a simple problem, because it indicates a beginning of the metabolic fobbing in the body, leading to different issues like PCOS, NAFLD, the increased insulin level, and as Dr. Das told, the diabetes and related complications. So the message is very clear, and this FAB-4 score can be calculated
Yes, it is there. In the app, it is there.
in the app.
Just add it and then you
from ACE, AST, ALT, and then the platelet count. So that can be done at bedside, and then you can take a call regarding how to approach the patient further.
Not even bedside, outpatient side.
Outpatient, yeah, outpatients also. So excellent talk. Give a big hand to Dr. Rao, and we'll take some questions. Couple of questions.
Sir, let me tell you, I place on record the amount of research that Professor S.P. Singh has done from Cuttack here with a simple things. He didn't have the big things what the big institute has got, but he's one of the persons who has brought the fatty liver into light. In the field work long back 2014 somewhere. This one.
The diabetic group had not accepted NAFLD is one of the expression of insulin resistance. I'm talking 30 years back. When he used to work in a center where there was a simultaneous ultrasound. He used to do endoscopy, and there was a simultaneous ultrasound. He had a very fascinated observation. Most of the people, hectic, obese, are coming with the ultrasound finding of the fatty liver. What is this? What is wrong going on in the liver? And I know him telling this and taking a biopsy. I told, sir, it's an invasive procedure and patient may not agree. I remember many people have not stopped bleeding and we had to admit them after the biopsy and DFO. And those who have done DM in the department, they know very well what's his passion for NAFLD and NASH. Now it's a accepted entity of insulin resistance, metabolic syndrome, and it's time to intervene. Sushant.
Sir, many times, as you rightly said, our mortality is because of cardiovascular disease rather than, fatty liver. Many times we see the physicians and they are reluctant to give hypolipidemic drugs in that case. So please throw some light why we are, that is for the benefit of physicians.
I know.
Yeah, it's a very good point which is raised, actually is raised for all of you purposes, this one, because we hepatologists and gastroenterologists, we keep shouting in all the meetings that please do not stop, or you can even start statins in people who have got elevated enzymes because of fatty liver, right? And you know that every diabetic will have a fatty liver, right? And there, unless they are very high, for which you have to find out a cause. Otherwise, what will happen? You add a statin and then it increases further, you think that the statin has done that one, right? And statins has got a lot of advantages, not only that one, in portal hypertension, in the anti-fibrotic agent, they are there. We keep telling our cardiology colleagues also, and also physician colleagues, not to stop, rather you can start the statins in this.
Irrespective of the lipid level. Many people see that the
no.
Our image is different. What sir is saying, liver enzymes is with abnormal, high. So many people, they're reluctant to start statin, or else they start statin, liver enzymes get elevated to view, they stop statin. So that is the point. We should not stop statin because basically the mortality is because of cardiovascular issues rather than fatty liver, and the researchers are knows that have shown the statins, they do not do any harm, rather they do good in case of.
So if there is an indication for starting the statins, don't stop it and they can start it. But those who do not have a lipids are normal, you don't have to start it just because it will protect the liver. That is not there.
Yeah, very right. And maybe just to add, statins even blamed to cause diabetes, to deteriorate the insulin resistance and cause diabetes. There are lot many blames on statins. And in social media, it's moving that it's a doctor's creation for the pharma mafia.
Few studies of rosuvastatin have shown that, but overall benefits of statin has more. And why? One of the reason why people do not start statin in this patient, because I always wonder why LDL level is not there in the metabolic syndrome definition. There's HDL and TG are there in the definition. I don't know why LDL is not. Many of the patients, LDL may be normal, that's why they're not starting a statin. But every patient of metabolic syndrome, you should go for a statin. Be it diabetes, be it non-diabetes. Diabetic, of course, you have to start statin. If somebody is more than 40 years, even if the LDL levels are, normal. And non-diabetic patients with little evidence of inflammation, you should start statin. So I just wanted to ask something. There are so many studies on saroglitazar in India. Even biopsy-proven MAFLD cases, saroglitazar is having some favorable effects. Why there is no talk about saroglitazar in NFLD, in diabetes? And recently, ADA had a guideline. They never talked about saroglitazar. They talked about everything else but saroglitazar. Though we have robust evidence in support of saroglitazar in biopsy-proven cases even in India.
Very right question. Actually, Professor Das is associated with saroglitazar movement and work very closely, and this is it being an Indian innovation. It has been taken to global level by many, but instead of all fight, it has not been recommended in the field. What is your opinion on saroglitazar?
On the contrary, it is the diabetic endocrinologists only have used that one in the form of a lipoglyn. Lipoglyn is nothing but a saroglitazar, right? We call it as a...
That's the brand name, sir.
Yeah, actually
they have two brands. One is Bilipsa, which gastro brand, and Lipaglyn is the
brand. Actually, initially, this Lipaglyn or a saroglitazar was used by the diabetic people in order to potentiate the effects on the lipids. And then they found out that the enzymes are also coming down. That's how the story has started with the saroglitazar.
It started with anti-triglyceride drug.
That's right.
Yeah,
that's
because
right. we in diabetes.
Yeah, because we didn't have many molecules, they thought that this will help decreasing the triglyceride, increasing the SDL, the Indian typical atherosclerotic dyslipidemia. But of late, it was seen of use to be in MFLD. So the new terminology we use is muffled, the metabolism associated fatty liver disease. So there, the evidence, I think Professor Mahapatra wants to say something regarding.
Sir, even your hepatologist, Dr. Ajay Dusaja, has done a study, I think last year, where he talked about saroglitazar in biopsy-proven cases of NFLD. It's not only the diabetologists who are using. He has a study, I think he has a large study.
Sorry, we are running out of time. So we have the next session.
Saroglitazar is still not accepted by the Western world and then other people. It's been accepted and then by the DCGI has approved that one. But the recommendation which is given by our own INASL is grade 3 and a weak recommendation. It is still, some amount of data is still yet to come, which has not been published, which has been done by the dual biopsy, which has been shown. So far it's been shown, experimental level, there is a good evidence is there, evidence to trial is there. And at the level of that one, it is been shown to reduce the lipids and also the enzymes is there. But the final proof of a biopsy is still yet to come. That's still not published.
Very well taken, sir. I think it's time. So, Rakesh, last.
Can I ask a question, sir? Can you use sear wave elastography instead of, sir, fibroscan, if fibroscan is not available?
Yeah, listen, you can do. Shear wave elastography is the one which is a software which is attached to the McCuson ultrasound sonogram itself. But what is important for you to see, the KPA levels are different in different things.
Yes, we know, sir.
That's a different thing. So you can use it. There's no problem.
We have to exclude other causes in case of fatty liver, sir, or directly we assess that it is a MSLD and we will start treating.
No, the one most important causes is a drug-induced liver.
Yes, sir. After excluding drug, sir, other things like Wilson's, autoimmune, should we rule out, sir? It's very expensive to rule out other causes. We generally do, sir, viral markers. And sir, alcohol, drugs, this thing we rule out, then we level it as MSLD. Sir, is there any other test we should do?
Actually, Wilson is a rare disease. It should not be overlooked. At the same time, you need not keep on doing the in every patient, unless there is a persistently elevated where you have ruled out other causes, where even the metabolic parameters are not there. But you can see that all of us, including me, and also the high-end corporate hospitals, everybody will do this one just because the simple investigation which can rule out, because Wilson's diagnosed very early is a totally controllable disease, if not a totally treatable. That's the reason. But we certainly agree that we are overusing some of these parameters.
Yes.
Thank you, sir. One last question, please. Be quick. We are 10 minutes behind schedule.
We are behind schedule. We have to go for the valedictory function.
Tea break is cancelled. So the coffee will be served in the hall. You request the coffee people to serve it at the hall. And thank you, Dr. Rao. Most of your time is taken by the course director and the chairperson, so the audience have not got opportunity.
Extremely sorry for that, but
you can interact with Dr. Rao. Because valedictory is at 1:30 fixed. But quickly finish another 3 presentation. So let us move ahead. Thank you, sir.
Thank you, sir.
Coming to the fourth session, I would like to request chairpersons Dr. Samir Sahu, Dr. Debakanta Mishra, Dr. Subhashish Pradhan, Dr. Kalpana Panda, Dr. Bharat K. Mukia, Dr. Namita Mohapatra.
So we have 3 chairpersons. That's great. So the purpose of keeping such a big team is at least half of them will be present. So I request the chairperson team to move forward. Please invite the speakers and we'll move forward. You have the program? Dr. Vinod Dikshit. So we have come to session 4 of the hepatology for physicians. This is approach to a pregnant female with incidental SBSAG positivity. You can invite this speaker.
So good afternoon, delegates and others. So nice. This is a very interesting and a very important topic. Approach to a pregnant lady with a HbS positive, and because mother to child transmission is very important, and that has to be prevented because these neonates who get infected from the mother, nearly 90% of them go to chronicity, chronic hepatitis B. So that's why the mother as well as the baby has to be taken care of with post-exposure prophylaxis for with vaccines and immunoglobulins to the child, and the mother also has to be decided how to be treated. Take into account the hepatitis, the E antigen and the viral load. So I invite Dr. Vinod K. Dixit to enlighten on this matter.
Thank you, Chairperson. At the outset, I would like to thank INASL, Professor Singh, Dr. Dusheja, and the non-AG team for giving this opportunity. As you rightly said, this is also one of the very important topic because most of the time when the gynecologists they come and they just screen for the hepatitis B, it's found to be positive, and they really become panicky now what to do, and they immediately refer the patient to either the physician or the gastroenterologist. I will discuss actually some of the aspects before going to the treatment properly. These are the outline of my talk that I will be discussing. Now, you see, it's a huge burden as far as the hepatitis B is concerned. Worldwide, 350 to 400 million people who are exposed to chronic hepatitis B. And particularly in Asia, 8 to 10% of the population, they are chronically infected with the hepatitis B. And up to 50% of these new cases are due to the perinatal transmission. This is very important. In Western world, actually, it's more of the horizontal transmission which is responsible, while in our country and the South Asian country, it is the perinatal transmission which is still the important reason for the transmission. So about 15 to 45% patients who develop actually this, they die of the complication of the hepatitis B related disease in the form of cirrhosis or hepatocellular carcinoma. Now, what are the modes of transmission? We everybody know. I need not to emphasize it. Any body fluid, but exposure to viral-laden serum is the most efficient mode of the transmission. It could be perinatal, as for the South Asian concern. Horizontal transmission is basically seen in the primary mode in Africa or close contact with the household. Sexually, primary mode of the transmission in US and the other Western countries by saliva, vaginal secretion, or semen, or parental, second most mode of the transmission in the United States. Now, for the transmission actually from mother to baby, basically there will be transmission risk, and these factors we can divide as the viral factors or the host and parental factor. Now, regarding the viral factor, as you know, it has got a 18 kilodalton secretory protein which has got immunomodulatory function, and replication is very important. If the virus is replication, then this is more infectivity. So maternal HBE basically is filtered through the placenta, so there is more chance of the transmission in these mother who are having the replicating virus. And more than 70% neonatal who are positive at birth, only 10% they get infected. And maternal HBE disappear by 6 to 12 months if there is no viremia. So viremia is also very important. If the viremia persists, then there is more chances of chronicity or failure of the vaccination. So detectable DNA has become now the important predictor of the hemophilic failure. This I will discuss later. Now, what is the mechanism of the high rate of the infectivity in the hepatitis E positive patient? Now, HbA1c positive correlates with the high maternal viremia, and the low IgG anti-HBC in HbE positive patient, there is a more chances of transmission. So maternal HBE is basically interfere with the T cell recognition, and that's why the telogen and make newborn immunological tolerant. So that is how there is a disturbed immunity, and which is responsible probably the patient of the hepatitis B E positive, there is more chances of transmission. Regarding the surface antigen, initially we thought the prenatal maternal HBE titer may be more important, but we know nowadays the DNA is a more important key predictor rather than the hepatitis surface antigen estimation. So mother with the occult hepatitis B infection, there is a very low level of perinatal transmission. Now, regarding the DNA viremia maternal transmission, maternal DNA is single most important predictor. And this is there are various studies we have shown that if the person who has got hepatitis B positive, E positive, and there is a high DNA, there is more chances of the transmission. And these are the few studies which I have just quoted. Besley from the Taiwan, where they have shown that person who having hepatitis B and E positive, there will be chance of 85% or surface antigen HBV 35% if it is HBV negative. And since their DNA is not much very high, that's why there is no vaccination required at the infant level. And similarly, the Jhao and other people, they have suggested if there is they have shown the correlation, if there is a high DNA, then there is more chances of the infectivity, and then there is a need for the vaccination and HBIGD to the infants. Now, regarding the genotype, whether it has got any role or not, because as for the hepatitis C, genotype is important for the therapy is concerned, but hepatitis B particularly, we don't have much of the relation as for the treatment is concerned. But Japanese study, they have shown that genotype C and perinatal transmission is more compared with the genotype B, D or A. China Asian population, where the genotype played more role in perinatal transmission because we are predominantly having the genotype B, C or even D. Escape mutants and risk of transmission, mutants of the S gene, either the vaccine induced or the spontaneous, they are not responsible for vaccine failure and risk of the transmission. And the role of the pre-core and the basal core mutation perinatal has not been fully explored. Now, regarding the maternal factor, there could be other factors like prolonged uterine contraction during the delivery, before the delivery, or there could be threatened preterm labor, or there is a linear correlation has been seen between the prolonged first stage labor, if it is more than 9 hours, and with the cord blood HbA1c level. So the transmission risk at the various stage, it is the highest with the antepartum around to the tune of highest with the interpartum is around 40%, followed by antepartum which is 10%. However, the risk is very low as in the postpartum area, or person-to-person transmission is again variable. Now, as we transfer antepartum stage, it could be region, either there could be male germline or maternal oocyte in early embryonic stage, or there could be a maternal peripheral blood mononuclear cells, cellular transfer, partial placental leakage at the time of threatened preterm labor, or amniocentesis. Now, amniocentesis in mothers does not increase the risk of hepatitis B transmission, and there are enough actually regions, or there are enough studies which have shown in the various, whether with amniocentesis or without amniocentesis, there was no statistical significant difference. So that's why the amniocentesis is considered to be safe in the patient who are hepatitis B positive. Now, the interpartum stage, particularly the hepatitis B transmission, it could be a prolonged first stage of labor, or there could be a trauma from the instrumentation, threatened preterm labor, direct contact with the infected genital tract, maternal fetal microtransfusion, or the surface antigen which is detected in 55 to 98% of the vaginal epithelial cells, 20% of the amniotic fluid, and 96% of vaginal fluid. So during this interpartum stage, this is one of the considered to be important actually where the transmission can occur. Now, the prolonged first stage labor, if it is more than 9 hours, then maternal transmission is more likely. So, linear correlation exists actually between the incidence of hepatitis B in cord blood and the duration of the first stage of the labor. Now, the postpartum stage, as I said, it is not actually much transmission occur during this stage. As for the breast milk concerns, it continues to be safe, though there is a the HbA1c positive may be 72%, but they are not considered to be unsafe. Gastric lavage fluid can have almost 90% hepatitis B positivity. So that's why the first breastfed actually infant, they are not considered to at risk of the transmission than formula fed baby if adequately vaccinated. And this is very important actually observation in one of the study of Bachelor, which have shown the group who was breastfed on those who were not formula fed, and there were no decline, and there was better actually who were the breastfed. So breastfeeding is not a contraindication if baby is adequately vaccinated. Regarding the genetic factor, higher susceptibility of the intra-uterine transmission in the newborn with the HLA-DR B107. But we don't have much of the data on this. Now, the prevention studies, what we can have, either we can divide at the antepartum stage or interpartum stage or the postpartum stage. Now, in the antepartum stage, basically we can give the HBIG to the mother also. In the before just delivery, the 3 shots of the HBIG can be given, or those who are having the significant disease, we can put the patient the nucleoside analog or nucleoside. And so the role of the HBIG and antepartum, you have seen in this is the study which have shown if you are giving the patient who have got a high risk of transmission, HBIG sometimes can be helpful in these patients. So HBIG inflammatory uterus may be interrupted by injecting multiple intramuscular HBIG injection before delivery without causing any side effect. Role of HBIG antepartum admission of the 3-dose HBIG for HBE positive mother is inefficacious. This is another study. So it's still controversial whether it does help or does not help, but it can be given safely. There is not much of side effect. As regards the lamivudine treatment to the prevent transmission, yes, this has been given. The people have given, they have compared this is a study by Johnville, where they have given the patient HBsAg positive at DNA who are having more than significant DNA, and they have given the vaccination, and along with that the patient was also put on the lamivudine, and they found the perinatal transmission was significantly less as compared to the controls. Now, role of nucleoside analog in the pregnancy in preventing perinatal transmission, and this is beyond any doubt. Those who are having the nucleoside during the pregnancy having the significant disease, by giving, whether you are giving tolbuprine or lamivudine or the tenofovir, this is quite effective, and the perinatal transmission is significantly less. Now, the treatment option for the chronic hepatitis B in pregnancy, either you can have when the already mother is pregnant, without any antenatal period, when the patient has chronic hepatitis B, active disease, patient having either the cirrhotic changes or which is compensated or chronic hepatitis, you can try with the patient with that finite therapy with the pegylated interferon, and which had not got a very high actually clearance rate, but they can have the potential side effect. Or the patient can be put at lamivudine or telbudine or entecavir, tenofovir. So nowadays, actually, now the entecavir and tenofovir, they are considered the better drug. They got high barrier, so they have less resistance as compared to the lamivudine, which has got very high resistance. Now, the role of nukes preventing perinatal transmission, tenofovir is most appropriate option who might need for continuing therapy for long term, and few reports of the use of entecavir or atropine in pregnancy, but generally not recommended. Nukes in hepatitis B carrier positive mother from 28 weeks of gestation may interrupt. MTCT means transmission of hepatitis B efficiently. Nuke is considered to be safe and more efficient than the hepatitis B immunoglobulins in interrupting the MTCT. The more effective in preventing transmission in maternal viral load is reduced by more than 10 to the power 6 copies per ml. So, if you see the algorithm, so if anybody who is pregnant come for the first time, you look for the hepatitis B surface antigen. At the same time, you also see the anti-HBs titer. That simply shows if it is positive, then patient has been already vaccinated or had got the already hepatitis B, which has been cleared. If the person is hepatitis B negative or anti-HBs is also negative, just vaccinate the high-risk group and vaccinate infant at the birth. But if the person is hepatitis B positive, then you have to do the DNA, you have to do the ALT/AST, and you have to do HBE antigen or anti-HBE. If the DNA is very high, more than 2 lakhs per international per minute, consider treatment at the period of around 28 to 30 weeks of the pregnancy. And consider the stopping the therapy just immediately after the delivery, or you can consider within 3 months after the delivery. But if the person is having not significant DNA, then you don't give any antiviral therapy, but consider them, but you give the vaccination and the HBIG to the infant and monitor this patient in future also. But if the person is hepatitis positive, active disease cirrhosis is considered, or patient has a chronic active hepatitis, significant disease, then definitely the patient is put on the antiviral agent. Now, intervention at the peripartum stage, basically elective cesarean section or forceps vacuum extraction during the delivery, whether it does help. Yes, there have been studies where it has been shown that elective cesarean section is considered to be better. There is a less chance of the MTCT as compared to the vaginal delivery. And even the elective and urgent cesarean section, of course, the elective cesarean section considered to be better. Now, intervention at the postpartum stage, HB vaccine or HB is to be considered in all the infant. This has to be given in the 3 standard doses. And there has been enough actually data, the meta-analysis, hepatitis B vaccine or hepatitis B vaccine plus HBIG, Cochrane data, and which have shown actually, particularly the vaccine and vaccine HBIG is effective in preventing infection in neonates of hepatitis B or HB negative mother. CDC recommendation for newborn vaccination, HBV vaccination, 3 doses should be given, each dose around 10 international units. First dose preferably within 7 days of birth. HBIG should also be given first dose intramuscular within 12 hours. HBIG beyond 48 hours efficacy is less. So testing for HBIG until 12 months of the age. These are the recommendations. CDC's screening for hepatitis B in the first trimester is strongly recommended. In women of the childbearing age without advanced fibrosis, planning a pregnancy in the near future, it may be prudential to delay the therapy. To pregnant women with the chronic hepatitis B and advanced fibrosis cirrhosis, therapy with the tenofovir should be recommended. In pregnant women already on NICU therapy, TDF should be continued with the ATP and nucleoside. In all pregnant women with the DNA more than 2 lakhs, this antiviral prophylaxis TB should be started. And breastfeeding is not contraindicated. So friends, the take-home message will be the hepatitis B positive mothers should be evaluated for transmission risk. Infants should receive the prophylaxis, and NUC during the 3rd trimester is in selected patient may be given, and the free feeding is not contraindicated, and elective cesarean section may be useful in selected patient in the patient going for may be useful in selected patient. Thank you very much.
Thank you, sir. Thank you, sir, for the excellent talk. Now, should we take the questions now? I think after the session. So, any questions from the audience?
It's a very important issue that screening we get a lady positive for the HBsAg, and then unless you become very careful for the baby, for the mother, and for the outcome of the pregnancy, you cannot give justice. So I think Dr. Dikshit has very well covered the topic, every aspect. So quickly, 1 or 2 questions.
There are no questions because there's no doubt. He has cleared all everybody's doubt.
He wants to ask.
Okay.
Please.
So, according to INASL guideline, the recommended we should start the therapy if the mother is positive at 24 to 28 weeks of pregnancy, and we continue for 3 months postpartum to prevent the flare. So, if my question is one simple doubt. So, when to take decision that we have to continue? After 3 months, if we are repeating the DNA, if it is persistently high, then we have to continue like the chronic hepatitis B treatment.
Yes, if the person has, basically what you have to assess is you have to assess the mother actually.
Yeah.
What is the stage of the disease? Suppose patient is already having a chronic hepatitis.
So my question is that prior the patient is not, don't know that patient was previously HIV positive. We diagnosed the patient that positive during pregnancy. So we started the antiviral 24 to 28 weeks pregnancy and we continued till 3 months postpartum. So my question is that priorly is not a known case of CSB. Now, but at 3 months, after 3 months we confirmation therapy, we do a DNA.
I agree. So I agree the person who is already receiving the therapy and even after the delivery for 3 months, you monitor the HBV DNA. Suppose the HBV DNA after 3 months at the interval, you find a very high DNA, still the patient has the LT means showing the chronic inflammation, then I think we should continue actually.
Yeah, so this will treat like a chronic hepatitis.
We cannot stop.
The
patient is having active infection.
And if at that after completion of 3 months postpartum it is low detection level, then we can stop the.
Yes, we can stop.
Thank you.
Because there has been seen that there is not much of flare up actually once the patient delivers most of the time.
Thank you, sir. Thank you, sir, for that nice presentation. And I think we should go to the next topic.
Thank you very much. Thank you, chairpersons. Our next session, for which I would like to invite chairpersons, Dr. B.K. Das, Senior Medicine Specialist, Dr. Ambika Prasad Mohanty, Dr. Vijay Behera, Dr. Hemant Nayak, Dr. Gautam Nath, and Dr. Niranjan Mohapatra.
Thank you and good afternoon, everybody. Can I request Professor Gaurav to come to the podium, please? This is a topic for the physicians, that is evaluation and management of ascites. You must be seeing ascites quite regularly. The diagnosis is not difficult. And cirrhotic ascites is almost 2/3. That means you must be seeing cirrhotic ascites. They keep on coming to you if you properly manage. But the mortality is very high. Mortality is to the tune of 50% in 2 years. And those who are refractory, 50% of them die in 6 months. So there is some gap in the management knowledge. To talk on that, Professor Gaurav is here. He is a professor in SGPGI, and what I have seen in last 2 days, his interest is also AKI, HRS, ascites, and multi other fields. He is a very good orator. Let us listen to him.
Thank you so much, sir. So nice. Pleasure being here. Respected chairpersons, senior colleagues, and dear friends. So this is an overview of, probably this need adjustment, of what I'll be talking about. So, world over, cirrhosis is the most common cause of ascites to the tune of 80-85%, but India it's slightly less, around 60 to 70%, with tuberculosis and malignancy also occupying important reasons for ascites. Once we have ascites, we need to find out the cause. So, any new onset ascites requires paracentesis. So does a patient getting admitted again with ascites, clinical deterioration, fever, signs of inflammation, abdominal pain, encephalopathy, mental changes, hypotension, etc. You have to rule out infection even if you are sure it is cirrhosis with ascites and patient requires admission. So new onset ascites and the patients requiring admission for ascites evaluation, you have to do that. Grossly, ascites is because of portal hypertension versus non-portal hypertension. Portal hypertension is a defining cause. All other causes except versus portal hypertension, and still portal hypertension wins the race hands down. So portal hypertension can be prehepatic, hepatic, and posthepatic. I am sure all of you are aware of that. The issue is why. Why does portal hypertension cause ascites, and why is it different from non-portal hypertension ascites? It's just I have circled on the right hand side corner. It is because of sinusoidal capillarization. The sinusoids becomes capillarized. That means, apart from thickening of hepatocellular plates, they are activated myofibroblast that leads to loss of sinusoidal endothelial fenestration. So albumin and protein cannot leak out easily when there is capillarization of sinusoids. There is increased thickness of basal lamina, deposition of extracellular matrix and fibrillar collagen. So when fenestrae are blocked, capillarization happens, then albumin and protein will not leak. Therefore in cirrhosis, albumin is not leaking, so we get high SAG, that is serum albumin minus ascitic fluid gradient is more than 1.1. That is low albumin in the fluid. Similarly, low protein. High SAG, low protein is because of capillarization of sinusoids. Protein is not able to leak freely. This is disrupted in inflammation and malignancy. You have SVP, you will again have high SAG but high protein, and malignancy will have high SAG, high protein. Conditions where things happen acutely, you don't get time for capillarization of sinusoids, heart failure, HVOTO, all these things will have low SAG and high protein because protein loses very fast. So this is a fundamental issue in formation of ascites in portal hypertension versus non-portal hypertension related ascites. Okay, so high SAG, discuss the concepts of high SAG, mainly liver related. Cirrhosis, alcoholic hepatitis, heart failure, chronic, massive liver mets, BCS, PVT. Low SAG is inflammation and malignancy. You have peritoneal carcinomatosis, peritoneal tuberculosis, pancreatitis, serositis, nephrotic syndrome. Once SAG is dealt with, the other issue is protein. Protein is high or low. Protein more than 2.5 is high, less than 2.5 is low. Cirrhosis will have low protein. Inflammation, malignancy, heart failure will have high protein. Now there are multiple other things that cause ascites. I have just given a list of things that can cause ascites. I'm sure all of you are aware of the mechanism that peritoneal carcinomatosis, liver mets, chylous ascites or TB forms. So to diagnose peritoneal carcinomatosis, our cytology positive. So you do the cytology, you'll get the results. Tuberculous ascites has high TLC counts, close to 1000 to 10,000. Ascitic fluid proteins are high, cell counts is high, lymphocyte predominant. You have PPT skin test that might be positive, and ADA is high. So what is this ADA? ADA is an enzyme found in lymphocytes and RBCs. It's a purine degradation enzyme which catalyzes adenosine deamination. ADA activity is increased in fluids in the body with TB, occasionally rheumatological conditions and malignant lymphoma, but TB is one of the very important conditions. We commonly do this routinely for TB. So, various studies have given various cutoff from 40 to 32 to 27 to 24 with a fairly good sensitivity and specificity. Many times it's very difficult to diagnose TB if almost all the tests are negative, but you have high TLC counts, lymphocyte predominant, high ascitic fluid protein, and ADA is high. Benefit of doubt empirical ATT are started by many physicians. So coming to the biggest cause now, cirrhosis. Now cirrhosis, what happens? Basically cirrhosis, as we see, liver becomes fibrotic. So fibrotic liver is almost like formation of a dam over the liver. The river here is portal vein. So there is obstruction to the portal vein flow. The river has two tributaries. One is the splenic vein, other is the SMV. SMV supplies the bowels. So when portal hypertension happens, there is congestion of portal vein, congestion of SMV. Congestion of SMV, there is Plancknic vasodilatation obviously. Congestion of SMV will lead to loosening of the tight junctions. Gut becomes congested, there will be bacteremia, there will be endotoxemia. This bacteremia and endotoxemia will go into the systemic circulation, produce nitric oxide and dams, and cause systemic vasodilatation. So in a nutshell, there is Plancknic vasodilatation plus systemic vasodilatation. Heart is over pumping and we are giving beta blockers to stop that heart functioning over time. So in effect, there is decreased effective plasma volume. It is because of vasodilatation of the two important venous systems. This would obviously lead to decreased GFR, renal vasoconstriction, fluid and water retention, ascites formation, and the whole gamut, dilutional hyponatremia, refractory ascites, HRS. The whole thing is in continuum. It starts with ascites formation and does not start with creatinine going up. Remember, it starts with ascites formation that worsens with worsening pathophysiology. So this cartoon depicts that initially you have normal flow in compensated cirrhotics. As the patient becomes decompensated, there is activation of sympathetic nervous system, ADH, aldosterone, and all these try to keep the effective arterial volume in check. But a time comes with progression that the compensatory mechanism fails and there is formation of ascites, worsening of ascites, and this happens with maximal activation of renin, angiotensin, aldosterone, sympathetic nervous system. You do plasma renin, all these values are very, very high. So apart from with maximal activation of sympathetic nervous system, you still have ascites and all its complication happening. So it is not the kidney that is at fault, it is the circulatory dysfunction that is there with persistently decreased effective arterial volume, decreased GFR. So this is again the cartoon that depicts the same. Increased portal hypertension, bacterial overgrowth, translocation, Plancknic vasodilatation, reduced cardiac output. The nutshell is the reduced GFR. Reduced GFR is in the nutshell. And how do we manage ascites? We go on increasing the dose of diuretics. It is like beating a horse that is obviously tired. There is no blood flow. GFR is decreased, but we want to increase the dose of diuretics and that leads to all the complications of ascites. So remember the pathophysiology, it's very, very important. This again a recent article that again depicts effective arterial blood volume, bacterial infection causing kidney damage that happens. So in this pathophysiology, the game changer is a concept called hemodynamic deficit. Now hemodynamic deficit, a patient can come at the first level where albumin is around 2.93, renal artery resistive index is normal, so it does not require much hemodynamic deficit. Probably albumin, diet improvement, diuretics should be enough to mobilize the ascites. But a patient may come with albumin of 2.4, renal artery resistive index very high to the tune of 0.8, 0.9, systemic vascular resistance very, very low, 500 or less, cardiac output is increased. So here the hemodynamic deficit is too much. So no two people with cirrhosis and ascites would be having the same amount of hemodynamic deficit. That has to be calculated. Simple tests like SVR, cardiac output, renal artery resistive index by renal Doppler has to be done. Simple urine sodium by potassium ratio has to be done to see what is the urine sodium coming out. These things are very important before we go on for treatment. The issue is to reverse the hemodynamic deficit, to make it as less as possible, So diuretic, this ascites that are difficult to mobilize can be diuretic resistant, intractable or recidivant. Resistant is lack of response to treatment, to high dose of diuretic. We hardly are able to reach this high dose of diuretics. Intractable are basically because of complications. You give the patient diuretic, he develops hypokalemia, hyponatremia, hepatic encephalopathy, AKI, all these are intractable. And recidivant is fast accumulation, at least 3 times every year. So we come to a case, 40-year-old gentleman, ethanol cirrhosis, regular ethanolic cirrhosis, has ascites. With ascites, he is tolerating a dose of furosemide 60, spironolactone 100, but is having an issue with recurrent hyponatremia and occasionally altered sensorium. So this is diuretic intractable ascites. He came to us in July 22 with progressive jaundice, pedal edema, cellulitis, oliguria. These are the labs that were there. His bilirubin was 3, albumin was 2.5, creatinine 1.48. Creatinine is less than 1.5. But this is again still a form of AKI, type 1 AKI, because baseline creatinine was 0.6. So it's almost double from that, though it does not cross 1.5, it's still AKI. He has SBP to start with. We did the hemodynamics, you see the map here is 74. 74 map is almost equal to a BP of 100 by 60. So 100 by 60 gives a map of 74. Now that is not good enough for him. All these patients should have a map at least more than 82. Systemic vascular resistance is low, 700 odd. It's not very low, but it is low for this patient. Renal artery resistive index is high, CVP is up, he has a MELD of 21, CTPC cirrhosis. So what are the issues in management? He has diuretic intractable ascites. He has hyponatremia. You can't keep on increasing the dose of diuretics. He has SVP. He has AKI type 1. And hemodynamic abnormalities or hemodynamic deficit is there. Effective arterial blood volume is low. He has a high PRA, high renal artery resistive index, and low SVR. So to treat ascites, this is the common dictum. 2 grams of sodium per day, start with diuretics, dual diuretics, around 80 to 90% would have good response. People who don't have good response, we offer them LVP, we offer them TIPS or transplant. So first of all, we have to know that patient is salt compliant or not. Now, salt compliant, we normally check 24-hour urine sodium. It's very difficult for patients to collect 24-hour urine sodium, urine at home, and then take 10 ml to the lab to get the urine sodium up, and then tell them the measured value also. So a simple test of urine sodium by potassium ratio in early morning urine and if this ratio is more than 1, can give you a rough estimate of urine sodium being more than 78-80 millimoles per day. At that urine sodium, patient will not accumulate ascites. So ROC curve is good if you take the urine sodium by potassium ratio, and that is taken as equivalent, more than 1 is taken as equivalent to the urine sodium more than 88 millimoles per day excretion. Now if urine sodium by potassium ratio is low, patient has high risk of development of AKI. You should not push the dose of diuretics up. You have to think of measures to increase the effective arterial blood volume by albumin or vasoconstrictors, mirrodrine, Turley, whatever. Should not push the dose of diuretics up. Then patient is on beta blockers. Now beta blockers with low MAP, low blood flow to the kidney, obviously it will further reduce the cardiac output. This will be having deleterious effect as patient has low MAP for this state, AKI, SVP. So there are, for him, the window for beta blocker is temporarily closed now until we get him out of the woods, get his AKI cleared, control his SBP, get his hemodynamics better. So non-selective beta blockers may be withheld if systolic BP is less than 90, hyponatremia, or presence of AKI, as we have in this patient. Now coming to the role of LVP, albumin and sodium. LVP, we all know, you have to give 6 to 8 grams of albumin for every liter of ascitic fluid tapped. Albumin has been found to be the best solution, but apart from albumin, studies have shown that you can also give terlipressin and NORAD. So what does this tell you? This tells you that either you can increase the intravascular volume or you can vasoconstrict. Both are equal. You can vasoconstrict, give splanchnic vasoconstrictor or a systemic vasoconstrictor with as NORAD. Or you can increase the osmotic pressure with albumin. Everything is equal, prevents PICD. Basically, it is the play of volume, volume and volume. Effective arterial blood volume has to be maintained. So, time is running out. I'll just go to the hyponatremia, dilutional hyponatremia. Dilutional hyponatremia, obviously you have to restrict water. Hypertonic saline is not recommended in cirrhotics. It's recommended to partially correct hyponatremia before liver transplant. You give albumin 1 gram per kg, that is good enough to push the sodium up. Albumin has been found to be very effective to reduce mortality in dilutional hyponatremia. It also increases the intravascular volume. Again, this is stage 1 AKI. What to do here? Discontinue nephrotoxic drugs, stop beta blocker, identify, treat infection, SBP being the case here, and expand the volume. It can be because of the things mentioned above. Now, other thing to look out is you should not keep on increasing the diuretics because there is resistance. Why is there resistance to diuretics? The resistance can be pharmacokinetic or pharmacodynamic. Pharmacokinetic is you keep on increasing the dose of diuretics to get the same effect. After some time, it doesn't work. It is because furosemide is not reaching the tubules. The effective arterial blood volume is less, albumin is low, renal artery resistive index is high, GFR is poor. So furosemide has to reach the tubules to act. So the curve is shifted. Just 2 minutes, sir. Finish.
You have to answer some questions.
Yeah,
definitely.
A couple of minutes to finish off. So that is why furosemide resistance is there. No point jacking up the dose of diuretics here when you have an AKI and an SPP. Volume expansion is more important than jacking up the dose of diuretics here. Resistance is there. This is the crux pathophysiology. Vasodilatation and hypoalbuminemia. What it causes is reduced GFR. Have to consider vasoconstrictors here. And midodrine is one of the better vasoconstrictors. Midodrine with vaptans have been shown to be effective. So I'll stop now and rest of the things I'll try to answer in questions if any are there. Happy to take questions, please.
Thank you, Professor Gaurav, for your brilliant talk. I want to ask one question. In case of tubercular ascites, you suspect tubercular ascites, but you are not getting on usual tests any contributory finding. So do you go for a IGRA test so that you can confirm?
So IGRA test is not confirmatory. Many times people didn't used to do that. It may be a supportive bystander. So it basically does not give you the present levels. It's not an IgM test. So it does not say that you have TB now. You may have or you may have had previously. That's what we are sure of. So it's not confirmatory. It may be supportive. The main issue is you have to look at the overall clinical picture, try to get biopsies, peritoneal thickening, lymph nodes. Those are more important than IGRA test.
Thank you. Another question. Well, there is hyponatremia, simultaneous use of diuretic and adding tolvaptan. Will it solve some purpose?
Yeah, so basically tolvaptan study I didn't show. Tolvaptans have shown to have no benefit on survival. So it's not benefiting survival. Now we have a condition where ascites is formed, so volume is less. Renal artery resistive index is low. We are trying to give furosemide, diuretics that act on the proximal tubule distal tubule. Tolvaptan acts in the collecting duct at the absolute last. So fluid has to reach there for tolvaptans to act. The main issue is to get the GFR correct so that more fluid reaches the kidney, so that diuretics and tolvaptan act.
Okay. Sir, thank you very much.
Thank you.
Thank you, Dr. Gaurav. It's an excellent presentation.
We are running short of time. We are late by 10 minutes, and this is the last topic. So we should be on time at least. So
Thank you very much.
after this session, there should not be any questions because we have the valedictory function coming up in 10 to 15 minutes time. So we won't be able to give any questions for the audience.
Thank you, sir. For our final session, I would like to call chairpersons Dr. Anupam De, Dr. Kavalya R. Das, Dr. Amitav Roy, Dr. Manjit Kanungo, Dr. Suprabhat Giri, and Dr. Swarup K. Patnaik. Please join the stage, sir. Stage is yours.
Thank you. So we have come to the last talk of the day, and this talk will be space occupying lesions of liver. And for that, I will invite Dr. Harish Bujade from PGI Chandigarh to deliver the talk, please.
So good afternoon, everyone. So I think this is the last session of this conference, and from the colorful presentation, I am taking you to the black and white pictures because I am a radiologist. So I will show you a last picture which is also black and white.
Sir, full screen PPT.
Okay. So thank you.
First slide, go back. Next.
नहीं मिला
उसी में आ गया था ना
हाँ
maybe
Not while they fix this problem. You can just start with a few introductory lines and then something about the topic.
Yes, sure. So sorry for the glitch. I can start with this only. Yes. Fine. So I am talking about the focal liver lesion. So these are the discrete abnormality arising in the liver, and because of the extensive use of the imaging for the various diseases, we can have the incidental focal liver lesion, or we can have some specific liver lesion which are which are seen on screening in the cirrhotic patient or patient having extrahepatic malignancies. So this focal liver lesion can be benign or be malignant, and we need a right approach to diagnose this lesion. So before going ahead to the imaging, we need to consider certain things: whether patient is symptomatic, this is the incidental, or this is screening, this lesion is detected on the screening. Is there any history of hepatitis, or is there any extrahepatic malignant disease? When patient is cirrhotic or not. Then we have various imaging modalities like ultrasound, then CT scan, MRI. In ultrasound, we can characterize the lesion, whether it is a solid, whether it is cystic. We can use Doppler to see flow within the lesion. Most of the solid lesion may not show the flow, but we can certainly diagnose portal vein thrombosis on ultrasound. Then we can have contrastional ultrasound we can use for the characteristic enhancement of this lesion. Then in CT, we have multiphasic CT, in which we can characterize the lesion based on the enhancement pattern. Then on NCCT, we can see the calcification to space in certain lesion. Dynamic MRI also important to characterize the lesion, whether lesion is showing enhancement, arterial enhancement or delayed enhancement. Then the vascularity within the lesion. Then fat within the lesion can be characterized with the help of MRI using the chemical shift imaging, that is in phase and out phase imaging. Then there are certain new contrast agents which are specific to liver, that is these are contrast agents which show biliary excretion. So these are multi-hands. This is commercially available and it shows biliary excretion. So whenever we do delayed scan, we can see there is a, where there is a hepatocyte, there will be excretion of this contrast. Then there are few advances in the imaging like elastography, MR elastography. So coming to CT versus MRI, which modality to choose for the focal liver lesion? So CT requires less patient cooperation, it is readily available, it is cheaper than the MRI, not ultrasound, and it is not affected by the large volume of ascites. However, it has radiation hazard. Coming to MRI, MRI has additional sequences. We can use diffusion weighted imaging to see whether lesion is diffusion restricted, that is highly cellular lesion. We can differentiate between the benign and the malignant pathology. MRI has a high spatial resolution compared to CT, and there is a hepatocyte specific contrast agent we can use for the MRI. But MRI has certain disadvantage like high cost and the we cannot do in patient with pacemaker. This is the long list of benign and the malignant tumor. I am skipping the list, and I am coming to the basics of ultrasound because the first modality to characterize the lesion is the ultrasound. So whenever we found any lesion in the ultrasound, first we will go with the ultrasound. On ultrasound we can characterize whether it is a cyst or solid. Then on internal echogenicity we can see whether it is anechoic lesion or it is hypoechoic lesion, isoechoic or the hyperechoic lesion. So coming to anechoic lesions are the cystic lesion. So this cystic lesion will have the very thin wall. There can be a posterior enhancement. This is looks bright. This area looks bright. That is posterior enhancement, and the wall is very thin or imperceptible wall. So these are the simple cystic lesion. Complex cystic lesion, then there is an internal echoes, irregular thick wall or thick septation, calcification or mural nodality within the lesion. Example of complex cystic lesion is an abscess. So in abscess, we can see on ultrasound, this is cystic lesion with internal echoes. This is again internal echoes with the shaggy margin. So these are the liver abscess. This is another patient with the internal echoes, septation and the shaggy margin. And on CT, these lesions are cystic with peripheral rim enhancement and the shaggy margin. So these are the complex cystic lesion and the abscess. Coming to hydrated cyst, these are the complex cyst with well-defined wall containing double echogenic lines separated by hypoechoic layer. So this can be multiple cyst can be seen within the cyst like daughter cyst, and this show multiseptate appearance, cyst within cyst appearance, and on CT we can see the internal membrane within the cystic lesion. So this is very characteristic of hydrated cyst. Some of the neoplastic lesion may be having cystic appearance. So most of these are the cystic benign like biliary cyst adenoma or cyst carcinoma or metastatic lesion. So the metastatic lesion will show cystic component, but you can see the wall here is very thick and it is showing some target appearance. So this is very characteristic of the metastatic cystic lesion. Coming to solid lesion are hyperechoic. Hyperechoic means bright and hypoechoic means black, and anechoic is completely or carbon black. So solid lesion can be hyperechoic or it can be hypoechoic or isoechoic. So example of hyperechoic lesion, this is a well-defined hyperechoic lesion with there is some posterior enhancement, and this is incidentally detected. This is small size. So this is the characteristic of hemangioma. So now we have seen the lectures of fatty liver, and there is an increased incidence of fatty liver. So these lesion in fatty liver will appear hypo because now background liver is more echogenic or more bright than this lesion. So this will appear hypoechoic. So whenever this type of lesion comes, and this is solid lesion and hypoechoic, we take the help of cross-sectional imaging like MRI, which shows progressive filling on this is arterial phase, this is portal venous phase, and this is delayed phase. So this lesion is filling from the periphery to the center and following the blood pool. Here it is following the aorta, it is following the portal vein here, and here the intensity match with the IVC. So this is characteristic of hemangioma. Now there are certain hyperechoic lesion but with peripheral hollows. So these are bright lesion with the peripheral black ring. So this is commonly seen in metastasis, hepatocellular carcinoma or the adenoma. So in metastasis, I already showed the cystic lesion. In this lesion, you can see there is a hypoechoic black ring around this lesion. So this is a target appearance, and this is also a characteristic of metastasis. Similar type of lesion can be seen in the granulomatous infection like TB, fungal and sarcoidosis, but we need appropriate clinical setting to differentiate between the multifocal metastasis and the multiple, because these lesions are also subcentric and multiple. So this is one female patient with history of contraceptive oral pills intake, and we can see the hyperechoic lesion, and on the periphery there is a subtle hypoechoic or the black ring. So whenever there is a black ring, we suspect it can be a malignant or it can be an adenoma or the solid lesion. So we need cross-sectional imaging. On cross-sectional imaging, you can see this is arterial enhancing and showing washout. So arterial enhancing, washout, well-defined, hyperechoic on ultrasound with peripheral hollow. This is the characteristic of hepatic adenoma, and this is more commonly seen in female with contraceptive use, and clinically all the clinicians are there, so they better know the clinical aspect of the hepatic adenomas. Another sequence in the MRI is in-phase, out-phase. I already told this is called chemical shift imaging. So in this area, we can see there is a slight hyper-intense bright lesion, and on this is out-phase image. We can see there is complete signal drop. That means this lesion containing fat. So this is again in favor of hepatic adenoma. Coming to non-hyperechoic lesion, non-hyperechoic lesion can be hypoechoic or isoechoic. So focal nodular hyperplasia, these are mostly isoechoic. We cannot differentiate this normal parenchyma and this is subtle lesion here. We can see the capsular, this is capsular bulge over there. So we can see there is a lesion here, and these lesions are mostly isoechoic or hypoechoic. However, we can sometimes see the center hypoechoic area which correspond to the central scar of focal nodular hyperplasia. So on cross-sectional imaging, it looks as a lobulated lesion and showing arterial enhancement, washout, and there is a central hypodense scar. So this is very typical of focal nodular hyperplasia, and this is MR picture showing this scar, and on dynamic MR also. So this is the lesion, and the scar is not enhancing in the initial phase, but on delayed imaging we can see the scar is enhancing. So this is typical of focal nodular hyperplasia. Then many times there is a confusion between FNH and adenoma. So FNH are iso or heteroechoic on ultrasound, and adenomas are hyperechoic. Then the central scar enhancement, the FNH has central scar, so it shows central scar enhancement in the delayed phase, and while the adenoma don't have any central scar, and it shows rapid enhancement of the whole lesion and the washout. Then there is a contrast written on delayed imaging in FNH in the center. There is no such thing in adenoma. So coming to the hepatocellular carcinoma, these have variable echogenicity on the ultrasound. This can be hypoechoic, heterogeneous, or the hyperechoic. So evaluation of hepatocellular carcinoma, as we know, there is a decrease in the portal vein blood flow and increase in the arterial supply. So hepatocellular carcinoma is purely supplied by the arterial circulation. So what happens is, in the arterial phase, this lesion enhances, and in portal venous phase, there is a washout within this lesion. So another feature of hepatocellular carcinoma is a fibrous capsule. So we can sometimes see there is a fibrous capsule on the NCCT, or on MRI we can see hypointense ring around the lesion on the T2 weighted imaging, or on delayed imaging we can see there is a ring enhancement of this capsule. This is on the CT and this is on the MRI. So pseudocapsule or the fibrous capsule is another feature of hepatocellular carcinoma. Then when there is a background cirrhosis, there is a lesion and there is associated portal vein thrombosis, and this thrombosis is showing neovascularity. That means it will show enhancement in the artery. This is contrast in the aorta, and this thrombus is showing enhancement. So it will show the thread and streak-like areas within the thrombus. So this is hepatocellular carcinoma. This is how this lesion looks on ultrasound. This is early arterial phase, late arterial phase, it is enhancing, and in portal venous phase we can see the washout, and delayed phase this is showing washout. Lyrates is used for the specifically for the hepatocellular lesion, and we should use in the cirrhosis, hepatitis B virus, or the when patient has current or prior SCC, and it is not used in when there is a cirrhosis due to congenital hepatic fibrosis or cirrhosis by vascular causes. This is the algorithm for the Lyrates. So LR1 and LR2 lesion means benign lesion. LR3 lesion is a borderline lesion. LR4 probably malignant, more toward HCC lesion. LR5 is definite SCC lesion. And LRM when there is a no arterial enhancement or there is a targetoid enhancement, then we characterize this lesion as LRM, and this is non-SCC malignant lesions. So one example of cholangiocarcinoma in this image, we can see there is a peripheral rim enhancement, no washout on subsequent phases. This is showing a targetoid appearance. So this is characteristic of cholangiocarcinoma, and there is a
Dr. Harish, can you please wind up? Okay. We are getting late for the valedictory, so we request you to.
Okay. And this cholangiocarcinoma also associated with the IHBR or dilated IHBRD. This is just two example. This is one solid lesion on ultrasound. However, on CT it shows peripheral enhancement, but we did MR in this patient and we found that this is the purely cystic lesion. So this was actually a case of hydatid. Sometimes hydatid may show solid-like appearance, but this may not be the malignant lesion. Another case, multiple lesion here, conglomerative lesions. And when we did ultrasound, we showed this leaf-like structure within the gallbladder and this multiple hyperechoic lesion. So this turns out to be the fasciola hepatic. So approach I already told, first we need to have the clinical history, and then based on ultrasound finding and complement with the TPCT or the CMRI, we can characterize this lesion. So all the lesion we cannot characterize, sometimes we need the biopsy, but most of the lesion, liver lesion, we can characterize. So this is my last slide to show you how the black and white looks. These are all sketches made by me. So this is all about the black and white imaging. Thank you.
I find fantastic presentation. The approach to tumors in the liver, and it's very important. Many times physicians get confused when they come across such a scenario, and with PGI style and PGI data, Dr. Harish has given a beautiful outlook. I wish that more members would have taken the benefit. We can still take couple of questions if they are. Yeah. So the question asker award should go to you, because we have very few.
Limited knowledge. That's why asking so much. Sir, for hepatocellular carcinoma, during screening you can diagnose an ultrasound. So the modality of imaging is triphasic CT. So according to you, for any cystic lesion, do you recommend should you go for CT or MRI?
For all the lesion, we should actually, because of the availability issue in India, so we go first for the CT and it is readily available. Otherwise, MR has more advantage over the CT. So definitely when there is a cystic lesion with there is a complex features like thick septa or there is mural nodule or internal liquors, then MRI is best. But if you don't have facility of MRI or the cost is an issue, then you can do this.
Yes, my question is CT, MRI both is available. I am telling the ideal approach. Suppose I am done ultrasound, I find a lesion like solid and suspicious of any malignancy, straight I will go for triphasic CT. Cystic lesion I am particularly asking. Cystic lesion, that is MRI. It's not CT.
Cystic lesion with thin wall and simple cyst, you don't have to go with the CT or the cross-sectional imaging.
Okay.
You just need to follow, unless the patient is known case of malignancy and we are suspecting cystic mets, then you can go ahead with the alternative imaging. Or if the patient is known malignancy, you may not go with the CT, you go ahead with the PET scan.
And hydrated cyst, what do you recommend? Go for MRI? Or?
Hydrated cyst, MRI.
Okay, thank you.
Where actually the valedictory has started in Hall 1, and I request the chairpersons to give their concluding remarks and ask the organizers to wind up so that all can move to the Hall 1 for the valedictory followed by lunch. And I thank my co-directors, Dr. Chotra and Dr. Devanand, and all set of chairs and the very patient listeners and the attendees, because it's topics are so good. I wish that more of physicians should have been there. Thanking the organizers, Dr. S.P. Singh, Dr. Manoj Shahu, Dr. Paningrahi and the whole team. And I give it to my course director, Dr. Devanand, to have his words.
Thank you so much, sir. Not but the least, I would like to thank the chairpersons. Please kindly join us for the valedictory as well as lunch, and the delegates also. There are few mementos to be given to the course directors.
And let them give their final comment.
Yeah, any of you would like to comment?
Excellent presentation, Dr. Hayes. I just want to emphasize upon one point, that in a patient of cirrhosis, size is more than 1 centimeter with a typical feature of LIRAD 5, that is early arterial phase enhancement and delayed washout. There is no need to go for the liver biopsy. That is one point I want to emphasize.
Yes, liver. This talk is about the approach on imaging, and I have not covered the biopsy. So whenever such lesion comes to us, we directly go for the treatment, not the. But as a part of research, we have started biopsizing the lesion which are more than 3 centimeter. We are biopsying to look for the cellularity and the molecular level. This is for the research purpose, but biopsy is not needed. And these are before the taste or tear, we are doing the biopsy.
Thank you. I think we can conclude the session. Thank you.
Thank you so much. I would like to invite Dr. Chotra, Dr. Panda to come to the dais to receive the mementos.
Thank you.
After a whole 5 days of hard work, thank you all. You can join for the lunch.
Actually, the launch is open. The Lily Hall in this building and the 3rd floor in the convention, and the valedictory in the Hall 1. I request all of you to come to Hall 1, that's the 1st floor of convention, till end of valedictory. So then we can thank you all.
Thank you very much.